This episode is sponsored by yet another incredible company that I stand behind fully, and that is Bubs Naturals. Now, I've not only used Bubs products for 4 years now, but I've also had the founder, Sean Lake, on the show twice. And they are offering you, the audience of the Behind the Shield podcast, 20% off your entire order, and I will give you that code in a moment. Now, Bubs has a very powerful backstory. Glenn Bub Doherty is one of the 2 Navy SEALs killed protecting the CIA facility in Benghazi. And wanting to honor his best friend, Sean stood up this company. Now, it began with their flagship product, which is their collagen. And I have to say, as a Brit with really dry skin who's now 51, I cannot underline the importance of collagen in your diet. I have seen a huge positive impact on my skin, nails, hair, and most importantly, digestive system. Another thing that I use religiously is their MCT creamers. That's the part of coconut oil that is good for our brain. And they come in dairy and non-dairy, depending on your diet. Now, I started taking Bub's latest product, creatine, about 3 months ago. And that was primarily because it's been proven to improve cognition and brain health. But not only did I witness that, I also saw an improvement in my performance, my lean muscle mass, and even a reduction in inflammation and sports injury pain. Now, in addition, Bubs makes apple cider vinegar gummies, vitamin C, and their hydration product, Hydrate or Die. And several of these products are also NSF certified, which is the highest level of certification as far as efficacy and cleanliness. Now, one of the most important elements of this company, in my opinion, is that they are a social business, meaning 10% of their profits go to charity, and in this case, that is the Glenn Doherty Foundation. Now, as I mentioned before, they are offering you, the audience of the Behind the Shield podcast, 20% off your entire order if you use the code BTS at bubsnaturals.com. And if you want to hear more about the products, the backstory, and how Sean used Glenn's story to help other veterans, listen to episodes 558 and 1055 of the Behind the Shield podcast. Welcome to the Behind the Shield podcast. As always, my name's James Gearing, and this week it is my absolute honor to welcome on the show cardiologist, sheriff's lieutenant, and U.S. Air Force veteran, Jonathan Sheinberg. Now, as you just heard, Jonathan has such a unique perspective, being both in law enforcement and a cardiologist. So we discuss a host of topics, from his journey into the world of medicine, his transition into law enforcement, heart disease and first responders, shift work, the Public Safety Cardiac Foundation, and so much more. Now, before we get to this incredible conversation, as I say every week, please just take a moment. Go to whichever app you listen to this on, subscribe to the show, leave feedback, and leave a rating. Every single 5-star rating truly does elevate this podcast, therefore making it easier for others to find. And this is a free library of almost 1,300 episodes now. So all I ask in return is that you help share these incredible men and women's stories so I can get them to every single person on planet Earth who needs to hear them. So with that being said, I introduce to you Jonathan Sheinberg. Enjoy. Well, John, I want to start by saying 2 things. Firstly, thank you to our mutual friend and my former guest, John Natolo, for making this connection. And secondly, I want to welcome you onto the Behind the Shield podcast today.
Thank you. It's great to be here. I'm excited to get to know you a little bit and talk.
Absolutely. Me too. Well, you just alluded to it before we hit record, and I didn't hear it yet. So how do you know John? And talk to me about him through your eyes.
John Natolo, who started as I knew John back in the 80s. We grew up together. We went to high school together. John was a football phenom back in the day. He was a running back and he was an unstoppable guy. And then John, we stayed in touch a little bit, but I saw him again at our 40th year reunion, and it was like we had not taken a day apart. He's a good man, and I'm very glad for the introduction.
Yeah. Yeah. Well, this is what I love about this now. People say, do you struggle to find guests? I'm like, well, there's ones I reach out to that people respond less these days than they did 10 years ago. That's a whole other conversation about emails and communication. But I get so many people introduced through the circles from other guests now. And this is why we're having this conversation today. So very first question then, where on planet Earth are we finding you today?
I'm in Austin, Texas, where it's about 107 degrees outside.
Yeah, I'm in Florida. The same.
Yeah, it's brutal. So I'm glad I'm inside. But originally, I'm from New Jersey. Grew up there. That's how I know John, your previous guest. Went to college in Virginia, med school in D.C., spent 15 years in the military, and ended up in Austin, Texas about 24 years ago.
Well, let's start at the very beginning in New Jersey. Tell me where you were born, and tell me a little bit about your family dynamic, what your parents did, how many siblings.
So I was born just outside of New York City, a suburb of New York, Livingston, New Jersey. Family dynamics, not much. I'm an only child. And not only am I an only child, my parents had no brothers and sisters. So I grew up with no aunts, uncles, cousins, brothers, sisters. And because of that, my friend network has been very important to me. So I have the same group of friends that I've had for over 50 years, and we still talk on a regular basis. So grew up there. In fact, tying everything together, interestingly, in Thanksgiving of 1985, I was playing football for high school with John Natolo and got hit, got a concussion. And in the back of the ambulance on the way to the hospital, I'm looking around, my head is taped to the board. I'm thinking, wow, this is pretty cool. I should become a EMT. So I became an EMT. And doing that got me interested in two different pathways. Interested in being a physician and interested in being further into public safety and becoming a cop. And I wanted to be in the military. So I'm fortunate enough over the last, we're now 40 years that I was able to be a police officer, a physician, and have a career in the military. So I was able to put it all together. I'm very lucky.
Amazing. I actually had a similar background. I wanted to be a stuntman, a firefighter, and a doctor. Now, I became a street doctor, not a ER physician or a cardiologist, but ended up doing the same things. It's funny when you look back and you're like, actually, if you're a little boy, sometimes you can do all the things that you wanted to do. You just got to find the right path.
My wife and I have 6 kids, and I tell them the same thing. You can do anything you want. You can, if you work hard and you're dedicated, there's nothing you can't do. And even if the positions are, you can be a physicist, poet. You can be anything you want to do. If you want it bad enough, you can do it. And I was an example of that. So I went to medical school. I became a cop first, went to medical school, spent 15 years in the military, got out of the military, became a cop again, went back to the police academy. And over the last 15, 18 years, I've worked my way through patrol lieutenant, SWAT, the task force officer with the Marshal Service. It's been a very rewarding, all while practicing medicine. It's been a very rewarding career. I've been very, very lucky.
You mentioned Thanksgiving. What were holidays like when you had such a small, living family tree? Were you around a lot of friends and family, or were they just very intimate celebrations?
Very small family celebration, because then my parents got divorced. So it was either me and my mom or me and my dad. A couple, scattered grandparents and distant cousins, but no big family. And but I didn't know any better. I did not know what I was missing. It's interesting because now I'm married. We have 6 kids. I have 3 kids. My wife has 3 kids, and they've known each other for, decades. So they grew up together. But when we first got together, the kids would be arguing, and my wife would just say, let them figure it out. Don't worry about it. They'll take care of it. And it was all alien to me. I didn't know what it was like to have a big family. I didn't know what it was like to have big sit-down dinners and Sundays dinner time. Everyone stops what they're doing. We get together for Sunday dinner. So now that I have a big family, I love it, but I didn't know what I was missing. And again, I had surrogate brothers, and it's been something that's been very important to me to keep up with my friends, because I talk to my friends that I grew up with more than a lot of people talk to their actual siblings. So we have a very good relationship, and that's because I was an only child and we all raised each other back in the day.
What were your parents doing as far as profession?
They were not professionals. My mother, she was a salesperson. She sold um, uh, liquor to liquor stores, and she was a copy editor in a magazine. And my father was a real estate salesman, and they were not in medicine. They were not on the job in law enforcement. They were just middle class working people in northern Jersey.
So where did the potential love of law enforcement come from, and or medicine?
That's a great question. And I'll tell you, the law enforcement thing, I've thought about this for years, and having been a cop for the last 30 some odd years, it is something I believe you're born with. People don't choose to be cops. You're born. I've heard firearms and defensive tactics instructors basically say there's really three kinds of people. 98% of the population are sheep, and the other 2% are either sheepdogs or wolves. And you're born as that. You're born as a sheep, you're born as a predator, or you're born as a protector. And I don't think I chose that profession. I think it chose me. And ever since I've been a little kid, that appealed to me. Like, your history in the fire service, never wanted to be a fireman. No interest, afraid of fire, never want to run into a burning building. The rescue doesn't, even though I did as an EMT for a while, the rescue component didn't really turn me on. But when it comes, I just hate bad guys. And I love being a cop. And then once when I told you, I became an EMT, and I'll tell you, what really drove that was not only that ambulance ride, but around the same time, I was probably 16 years old. I remember working as a busboy in a restaurant in Livingston, New Jersey, and I walk into the back, and there's the cook unconscious on the ground. I remember standing over him thinking, what in the hell what do you do? They called EMS. Back then it was called the first aid squad. They showed up and oh, he's going to be fine. And I'm like, how do you know? Like, I was so intrigued at how these people knew that he was going to. It's interesting. It turns out that he just smoked a bad joint. But, 40 years ago, so he was really having a bad buzz. But so that got me down the EMT road, which got me into medicine and public safety. And in the late 80s, when the crack epidemic was really sweeping the country, the federal government had different programs to give different municipalities additional money to increase the size of the police departments. Massachusetts was hiring different agencies were hiring police officers for what they called, they were called, it'll come to me in a second. They had a program where they hire people for a certain amount of time. You get a job for a year or a few months. And after the grant ran out, you would no longer have provisionals. We're called provisionals. You would no longer have a job. But during that time, there would invariably be openings in the police department, and they would hire from the provisionals. But it was a way to get in and test the waters, and I loved it. Then I decided doing that is, I want to go to medical school. And of course, as a patrol officer, I had no money to go to medical school. So I joined the military. The Air Force paid for my medical school. I was a reserve officer while I was going to medical school, doing part-time reserve stuff. And then once I graduated, I went on active duty for 10 years. So I did a total of almost 15 years total. Was deployed overseas for that, did some time as a FAR for critical care team member and a critical care air transport team leader. Was out in Afghanistan and Turkey and Haiti, and got out of the military in 2004, and I've been here in Austin ever since.
I'm going to take you back to when you were talking about, again, the sheepdog, the wolf, the sheep, and why we find ourselves in these positions. As I have learned more and more and more from all these guests, whether it's personal stories of, mental health struggles and getting their way out, or the psychologists, or, all these different types of people, it has become very apparent now that a lot of us that wear a uniform, when we look back, had struggles in our early life, and I use that word struggles because if you can address it and you can work through it, it becomes a strength then, 100%. If you ignore it and box it up and push it away, it's going to rear its ugly head one day. And that's, I think, one of the reasons why we see what we see in the mental health side of our profession. When you reflect back now, were there elements of your upbringing that you think contributed, struggles that sent you into uniform to be the protector, to be someone that helps and protects because you felt what it was like to be preyed upon, or you built the armor? Some of these things that we see contribute to us joining these professions.
James, that is an incredibly insightful and great question. And the answer is absolutely. And I shared this over the last couple months or year. I've finally become to the point where I am anxious to share some of this information because in the effect that it may help other people. But my mother, growing up, was addicted to OxyContin. She was on that same problem that so many Americans had, and it ended up killing her in her early 60s. But she was hooked on pills for 20 to 30 years. And as a young person, an only child with no brothers and sisters and a mom that was an addict, if you can imagine the emotional toll that takes, the financial toll it takes, it's embarrassing. So I lived with this thing for years and never really talked about it. And finally, over the last few years, I realized that the addiction really didn't define her. It was something she struggled with, and she actually did the best she can. So I've had a very, very grateful to have the insight that when I got back from my deployments overseas and the craziness that was there is to be able to see a therapist. And I've had a therapist for the last 20 years since I've got out of the military. And I was able to have this kind of discussion brought up and realize it's actually quite common for people who have experienced the same thing I did to become, it's very funny, physicians, military officers, and or doctors, and I hit all three of them. So I'm a classic example of struggling in a position where you have no ability to have control over anything to trying to control your environment, and realize that, and I've had so much pent up anger and frustration at the situation and at my mother for all this, and then potentially my father for being somewhat complicit in it, even some of my mother's friends. But the reality is, over the last few years, I've forgiven her. It's not something, it's a disease. It's like, oh, I can't be mad at someone if they have diabetes because their pancreas isn't making enough insulin. Her brain was a brain she had a terrible motor vehicle accident, had multiple back surgeries, and back in the 80s, 90s, the doctor just gave out the OxyContin and benzodiazepines, and she was susceptible to it. She got hooked on them, and she struggled with it for years. And that was a very, very profound part of my life. And I've really got to the point now where I can look at this, share. As a matter of fact, I did a big post on LinkedIn a few months ago about this because it was the anniversary of her death, in the hopes that other people would read it and learn from it and potentially forgive their family members and realize that it's not their fault. It's nothing I did. And the embarrassment that I had of bringing kids home, or the repossessed car, or we had a house that got foreclosed on because she couldn't pay the bills. I mean, those things as a young teenager, they're very traumatic. But when you get to the point where I can deal with it as a grown adult, it really is something that was a huge stepping stone for me to become more aware of what's going on, and also give me the motivation to reach out to other people and say, look, what I've went through. I mean, we've had a narcotic pandemic in this country, and especially now with all the fentanyl coming in, but with Oxy and all the benzodiazepines, what I went through is, millions of people went through what I did. And if I can reach someone like that with a story like this and help them get beyond it, I'm making lemonade from the lemons, I guess, and I try to share my story. But that's an incredibly insightful question.
You hear it so much. You really do. And what's interesting, the ACEs, the Adverse Childhood Experience Score, on average, military first responders are about 6 out of 10. on average, the average incarcerated man or woman is about 6 out of 10. So what you're seeing is hurt children who then, and I want to get to this in a second with you, either meet positive mentors and get steered into a good direction, or they meet negative mentors and they get steered into a bad direction. And it's been amazing watching truly the metamorphosis of this conversation, especially with your community, with law enforcement, because you are the men and women that are told, this is illegal, go arrest anyone who's doing this thing. And I had the physician in Portugal who spearheaded their decriminalization of addiction program. That doesn't mean you can buy crack in the supermarket shelves. It means that if you are found with a user's amount and you're an addict, you're not selling, you're not smuggling, you are not even detained. You are educated on the resources that are available for you. You are not forced to use them. So you're given your autonomy. You're not given a criminal record that stops you from getting a job and housing and in the vicious circle. And they reversed their opioid crisis in less than 10 years because they took an altruistic medical approach to addiction, just like you're talking about. They were compassionate when people were drowning in guilt and shame. You compare that to the lock 'em in the box, chain gangs in Arizona. We're adding shame and guilt to shame and guilt, and then we're driving these people into the underworld. So it's you hear all these real experts, and you start hearing these real lived experiences of people that are recovered now, and a functioning member of society, and they're paying taxes and holding down jobs, and got their own housing. We know the lock them up and fill them full of shame model doesn't work, and that everyone knows someone who has struggled with addiction, whether it's alcohol or opioids. And so I think hearing the law enforcement voices starting to say, we need to do something different. We need to use the same, I would argue, kindness, compassion that we're taught in a lot of our holy, books around the world, that is how we address, the opioid crisis, alcoholism, all these other ones, because we were fortunate enough to find our way to be a protector, whereas other people found their way under a freeway bridge. And we all started off as the same little kids.
Yeah. That's a tremendously powerful statement. Absolutely, I agree.
When you look back, who were the mentors that steered you onto that right path?
That's another great question. I have thought about this, and I've actually tried to thank the people that have had the positive. We all have positive people in our lives that change the direction of our lives. And I can tell you the first one was when I was in high school. My high school my 10th grade modern European history teacher, Mr. Ransignola. I was a C student, didn't get good grades, didn't care. He taught me how to learn. Just his class. It wasn't the material, but it was the way he presented it. He taught me how to synthesize information and learn. I went from a C student to an A student. That was one teacher, 40 some odd years ago. Then I had another teacher in high school who got me interested in science. Norma Grossman got me interested in science. And realized at that point I can do whatever I want. I mean, I had the ability to learn and do things. Went to medical school, and then when I became a police officer, there was a cop in Massachusetts, my first sergeant, and he was an old school sergeant back in 1989, Sergeant Cameron, and he also gave me a love of law enforcement, and showed me what it was like to not only, it's much more than just catching bad guys. It is a closed community that cares about each other, takes care of each other. And, at the end of the day, your mission is bigger than just selling stocks and bonds or whatever it is. So he was another influential figure in my life. I have had medical school professors that have guided me, but the people that I've mentioned so far have been pivotal. And there's two people in Austin, Texas, Sean Maddox, who used to be now the retired chief of Cedar Park, and Art Acevedo, who's the retired chief of Austin, Houston, Miami. When I was trying to get back into law enforcement after taking a hiatus for time in my military, they were very supportive. They gave me a chance. And they didn't just look at me like, what does this doctor want to do? This doctor wants to be a cop? Like, that's ridiculous. They knew that I had the experience, and they helped me set the stage to go back to the police academy, get my licensing again, and brought me on as a cop. So there's a few people in my life who really shaped the direction of it. And those are the folks I can, off the top of my head, can give a shout out to. And without them, I wouldn't be where I am today.
Well, I think this is just such an important point. They say you want to change the world, start at home. And absolutely, start in the mirror, look at yourself. And then obviously, as you did with your children, work on that as well. And then when you step outside your front door, what can you do? Can you start a firefighter mentor program? Can you, opening a boxing gym for the local kids? Can you mow grass of the elderly people? What is it that you can do to make your world a little bit better? And then, the ripples then, reverberate from there. But rather than expecting whichever political figure that you think is going to save the world for you and just putting all your time in being angry on Facebook, I think this is the thing that people need to hear. When they look back and they ask themselves, who were the mentors in my life? What if that mentor didn't give a shit? What if they're like, I'm not going to invest in John. I'm too tired. I'm just going to go and watch, Jerry Springer and forget about the world, but they didn't. They invested in these young men or young women, and they are now judges, surgeons, firefighters, cops, whatever they are, because those people steered them onto the right path. And had they not, they could be behind bars. They could be dead. They could be under a freeway bridge somewhere. So I think hearing these stories over and over again, and everyone that comes on with this, usually decades later, it shows the power of mentorship. And then it reminds us like, hey, that's you. It's your turn now to be the mentor.
Right. I've also had, outside of mentors, I've also had a lot of good friends over the years, friends that were my age, older, that have given me certain pieces of advice. I wouldn't necessarily say they were mentors, but certain things I've learned from people, which have also shaped some of the decisions I've made and behaviors I've done. And one guy, he was a interesting guy, was a Navy chaplain, chief chaplain of the Marine Corps eventually, Joseph Lamonde. He's a Monsignor. He passed away a few years ago as a Monsignor. He once told me, the most precious thing you can give someone is your time. That's it. That's the only resource we have that is truly limited. You can have money, give money to people. Sometimes it doesn't mean anything. You can give, no matter how much money you have, you can always give some. That helps. But give your time. That is something that you can't generate more of. And that is the best gift. And I've thought about that for years. And when I have an interest or a cause or someone who needs something, that is the most precious thing you can give someone, is just some time. And if you're able to sit down with someone, whether it's a young student and you're mentoring them, or from my perspective, a patient or someone you run into on a police call, your time is really what people want. And that stuck with me for years as well.
Well, let's talk about the front door of law enforcement. When you entered that first agency as a provisional, and that was because of the crack epidemic, what year was that, and what was the landscape that you were faced with back then?
It was 1989. So it was a long time ago, 37 years ago. And the landscape, when you say landscaping, that could be interpreted in so many different ways. The community landscape was completely different. We had no internet. There was no social media. It was just a completely different. We didn't have cell phones in 1989. And so the society was different. Policing in and of itself was completely different. We didn't have. I remember getting an old vest, an old body armor vest from some guy who retired. It was like an old T-shirt with padding, and it was horrible. It didn't fit well. And I remember some of the old timers looking at me, "You're wearing that? Like, what do you need to wear that? What are you, scared?" I had a Smith & Wesson L-frame revolver, no body armor, a radio that worked sometimes, but it was all analog. Walked a beat, and it was a different environment. It wasn't what it is now. And, with that, there was the other thing that was most that I think about constantly is we'd give someone a citation for, I don't know, running a red light or whatnot. And we'd go to court, and the judge would say, "No, the officer said he saw you go through the red light." But I didn't. "Nope, ma'am, the officer saw you do it." That's what it was. It was your word. Now it's the other way around. We see with our kids. When I was a kid, if my parents got called into school because I did something wrong, it was the parents and the teacher against me. Now the parents get called in the school, and it's the parents and the kid against the teacher. It's a very different dynamic. So the world was a little bit different. I'm not saying it was better. It was just different. And so those are the stark changes that I really recognize. The other thing, actually, while we're on this topic, this is interesting because, the way you lead your interviews, James, is they just kind of grow organically, and it's kind of interesting where the conversation leads. But the other thing I've noticed is our younger, because my wife and I have 6 kids, and they're all 18 and they're to their mid 20s. Actually, my daughter's probably in her late 20s now. What I've also noticed, which is with them and in the younger officers, is they don't have the ability to talk to people as well as those of us who grew up before social media and before texting. And this manifests in so many different ways. It manifests with people's ability to get along with people. It manifests in people's ability to use force, because we grew up, you had a problem with someone, you met him at the bike rack after school, you threw a couple of punches, and then you got up and you dusted yourself off and you shook hands and you moved on. It doesn't happen anymore. Now you do that and you go to jail, and then so people don't do it, so they hold all this aggression and they bring a gun to school. So the days of that kind of conflict resolution is gone because we don't have the ability to do that anymore. The young officers don't have the ability. They didn't grow up doing fistfights. So if they don't understand the application of force the way some of the older people, because it was more part of our vernacular. They tase someone if that doesn't work. They don't know what to do. I mean, again, the agencies train you, but the reality is I'm just talking about fundamental sort of going into the concept. The younger adults, I don't know what Gen Z is, whatever the new term is for the younger folks, they don't have the skills to interact with people the way some of us older folks do. I hate to say it like that, but it's the truth. I'd pick up the phone and call someone. My kids are terrified to call someone. They'd rather text or look and if they can't text, they want to reach out to them. It's really interesting. But those are what I see the differences between 1989 and 2026 when it comes to the law enforcement world.
What were you seeing as far as the crack epidemic itself?
Well, I was in an area that didn't have that much, but the Cape and Islands did have some. But again, it was. I think the biggest thing in retrospect now is the disparity between crack cocaine and powder cocaine. Powder cocaine being a white person, affluent problem, crack cocaine being typically a minority-driven inner-city problem. Same substance, different delivery mechanism, completely different social sex, and different punishments. And we in the 80s, the Ronald Reagan, George Bush 80s, we started throwing the book at all these people, considering the crack epidemic a severe crime problem and not a mental health issue and not a chemical dependence issue. And you can argue so many arguments have been made about the levels of incarceration that we have and the disproportionate numbers of African American or Hispanic people who are incarcerated because they're in the inner city versus the more affluent people, typically white, who's using the same substance in the suburbs on Wall Street, that get a slap on the wrist. So I think we've learned a lot. Things have changed. Again, I'm not saying things are worse or better, but we navigate this as a society. And we try to learn from at least my hope is we try to learn from our mistakes. But sometimes we don't, James. Sometimes we go around in circles and we do this, find ourselves doing the same thing over and over again.
This is what really turns my stomach. When I moved to America, it was now a decade later. It was 2002, and we found ourselves. Let me see. Initially, it was a little bit later than that. So I was in Orlando till 2004. Then I was down in Broward County, Florida. Now, anyone who knows the history of the pill mills, that's where they were. And my ex was working for a physician, and she was really confused about what the position was. This MD would write all these prescriptions. People would fly from New Jersey and all over the Northeast It's like, it's just so weird. We keep getting these people that show up. They're from, multiple states away. They get their prescription and then they leave again. And she got a bad feeling about it. And this was before it was really being made public. And so she left. Luckily, because I'm sure, an FBI or a DEA team would have burst through that door, a few weeks or months later. But then you start learning the backstory of OxyContin and the predatory practices of Purdue Pharma. And I think what that drug did is, to your point, you can't say, oh, that's a poor black person drug, or that's a gay drug, or whatever label you want to put it on, that you other it, because it was killing everyone. The poor white miner in West Virginia, and the affluent black judge in New York City. It was indiscriminate. But then I think as you saw the legal process move forward, and now that Richard Sackler is living in a mansion in America worth millions and millions and millions still. But as you said, the crack dealer in, inner city New York is still behind bars for what they did 30, 40 years ago. It does show, the extreme prejudice when it comes to wealth on what happens to these different people.
Yeah. Yeah. So hopefully we learn from it. I know as we learn, we make more mistakes, but as George Santayana said, those who do not study history are condemned to relive it. So now that I'm pushing 60 years old and wiser, I look at things and try to do and behave in a way that takes into consideration my experiences of what I've learned before. And then that goes back to what you talk about and use those experiences to mentor those young people coming up. I'll give you an example. I had a young lady with me this morning. Today I was working in my office as a cardiologist. Her father passed away a few years ago. He was a really good friend of mine. We served in the military together, went to medical school together. And she's just finished her freshman year in college, and she's wanting to go to med school. And I spent the day with her, showing her the ropes. And it's more than just showing, here, this is the material we learn. Showing them, here, this is the profession that I've chosen. Whether you're a neurologist, a pediatrician, a cardiologist, the tools are different, but at the end of the day, you're taking care of people, and there's a lot of fundamental similarities. So I try to use everything that I've experienced, and it's been quite a bit in 3 different professions, to use that experience to guide people and try to help them. And hopefully I've done a good enough job with my children. We'll see how that goes. Sort of jury's always out on that, but they're doing well. And if I can have the ability to positively affect someone else, it's a win.
100%. Talk to me about the medical side then. You enter the Air Force, you go to med school. What was your education like back then at that point?
So med school in the 90s was, no computers, no internet, no simulations. It was see one, do one, teach one. So we learned the first 2 years lecture. I went to Georgetown University School of Medicine in DC. We learned the first 2 years just lectures and beat into our heads, lots of exams, lots of memorization. And then your next 2 years of med school, you're in clinicals, you're doing rotations, learning the specialties. And then when you graduate, you basically have a medical degree, but no skills, because you've just been cursory exposed to a bunch of things. Then you do your internship, then a residency. So I did an internship and residency in internal. Actually, I did emergency medicine first. Did that for a bit, didn't care for it. It wasn't really my cup of tea, because even though I thought on the surface it carried all the benefits of both of the things I wanted to do, it really turned out to be someone comes in with a broken leg, you call an orthopedist. Someone comes in with a heart attack, you call a cardiologist. Someone comes in with a gunshot wound, you got to call a surgeon. And I wanted to be the definitive person. So I transferred from that to internal medicine. So after 4 years of medical school, I did 3 years of internal medicine training. And then I did 3 years of cardiology fellowship after that to become a board certified cardiologist, and started practicing in the Air Force in 2000 is when I got out of my training. So that was 26 years ago.
I've heard this from many people, but different eras when I went through med school. But you're an interesting realm because you're dealing with an organ that is directly correlated as far as health or ill health with nutrition, with exercise, with sleep, that I know we're going to get to. How much education did you have on the preventative measures when it came to the pillars of health, lifestyle choices, etc.?
Very, very little. 0%. I wish I could tell you, like, in animal 0.0. The reality is Western medicine is not geared, at least back then. They were making strides, but it was not geared towards prevention. It's not geared towards prevention for multiple reasons. Once you're out in practice, so you're taught by practicing physicians. Once you're out, I'll just give you an example from my specialty. It's changed over the last few years, but typically we have a fee-for-service model where you get paid on what you do. Now it's changing because now a lot of doctors are owned by hospitals. I'm owned by a big hospital system. But when you have a fee-for-service model, you get paid substantially more for intervening on a sick person than you do for keeping someone healthy. So for example, as a cardiologist, if I saw someone in my office, and my interest right now is advanced lipidology, so I'm a lipidologist. I look at cholesterol. I've done the whole gamut of cardiology. I came out of training putting stents in, hard cast pacemakers. I've done 10,000 procedures in my career. A few years ago, I had a bunch of back surgeries, and I peeled back the procedures, and I just see clinic now. But to give you an example, if I sit with someone for 45 minutes and go over what we call an advanced lipid panel, looking at cholesterol quantity, quality, inflammatory markers. And that once you do, it's a 3-pronged approach to keeping people healthy, which we'll delve into later, which is medication, lifestyle modification, and some nutritional concepts. That 45-minute visit would pay me $200. However, if I took 45 minutes, put a stent in a critical ill person having a massive heart attack, provided critical care, so same amount of time, 10 times more reimbursement, $2,000. It's disproportionate. So you're incentivized to let people get sick and treat them. Now, I got to be careful when I say this, because I'm not saying that doctors in any way actively want their patients to get sick so they can treat them. But in any business, if you're going to spend an hour working, you're going to spend that hour working in a role that generates this more revenue for that 1 hour. It's just human nature. This is why, historically pediatricians, family practice doctors, which are office-based, non-procedure-based specialties, make a fifth of what a interventional cardiologist would make, or an interventional radiologist, or a neurosurgeon. Those are practice-based, reimbursed much more highly for the procedures than what we see in the office. So what we learned in med school was really how to identify disease and how to treat disease. Very little done on prevention. That's something that we all have to learn on our own, and it's changed quite a bit over the years. So it's no longer as dramatic as what I described. Because now we know that prevention saves money. We work for these big systems that have anything from outpatient clinics to emergency rooms to tertiary clinics, hospitals, ambulatory recovery centers. So we have this big network now that we know that if we spend the money up front, we keep people healthy and out of the hospital. But that's a relatively new concept. That concept has been derived in the last 20 years.
As you said, and I want to underline it as well, most people out there, that took the Hippocratic Oath really want to make the world better, but they find themselves in these systems where they have a 10-minute consultation, a lot of them. They have patients walking through the door that have been groomed by drug companies in their commercials. Ask your doctor for, I would like this, please, for my thing. So it is a very, the system is broken. And I've said this, I come from a country where, when I was born in 74, so when I was young, I experienced NHS as it was supposed to be. The whole drive was keeping the nation as healthy as possible because it was a tax-based system. But if you got hit by a car, if you got cancer, if you had a child, you broke a leg, then the country banded together and it's like, we got you. I don't need your social security number. I don't need any payment information. Just come into the hospital. We'll fix you. And then you go about your day, which I really love. Now that system has been corrupted through attempted privatization and not yet acknowledging that prevention saves money, which we'll get to in a minute. But when you look at the American system, when, as you alluded to, the most profit is in sick people, that doesn't benefit the population. You know, the goal should be healthy, happy Americans, which in turn, I believe healthcare is a fifth of our GDP, which is insane. So even fiscally, it's extremely irresponsible. But, you know, after, for example, COVID, I said this, and when we came out the other side and there was a general acknowledgement that the more underlying issues a person had, the higher chance they were of dying from COVID, you would think the takeaway would be prevention is key. We need to address the obesity crisis. We need to address the mental health crisis, et cetera, et cetera. But we came out the back end and people were like, I don't want to talk about it. And I feel like nothing really changed. So you have such a unique perspective because you're literally dealing with people, a lot of people, not all, who I'm sure are victims of this broken system that are not driving people like maybe Scandinavia to be healthy and happy, but almost the other way, because there is a lot of money in sick Americans. It's just, you know, economics at the moment.
Right. So there's a balance. There's a balance that has to be struck between rationing healthcare and profiting from illness. And, you know, don't forget also here in the US, it's a little bit of a different environment because most of my colleagues come out. I was fortunate enough to go to medical school and have the military pay for it. But if you don't choose to go that route, you're going to come out of college with $300,000-$400,000 worth of debt, $500,000 worth of debt, if not more. So if you have that debt and you're looking at specialties and you're like, well, I like family practice, but I also want to be an orthopedic surgeon. The orthopedic surgeons are going to make 3 times as much as a family practice contract. That is going to have an impact on where I choose my specialty. Or I'm going to get paid more in this part of the country than I would be in this part of the country. So that's going to also choose where people live. So we get these medically underserved communities that don't have the right physician because they don't have the base of private insurance. Maybe it's more of a Medicare or Medicaid environment. So it's a multi-level problem, and no one really has been able to fix it. I don't have the answer. I know the answer lies somewhere between fully fee-based service and national health care. I don't know where that line is. And it's going to be different for every single person. But the question, of course, is healthcare a right or is it a privilege? And that's what we have to struggle with Americans. I think it's a right. Now, do I think that everyone should have a private concierge doctor that gets their phone number and all that? Not necessarily, no. But I think everyone is entitled to a level of care, which is a preventative, life-saving level of care. And if you want to go to a place that's got an MRI machine, that's got a little coffee bar in it, and you don't have to wait as long, okay, you want to pay more for that? I think that's great. But you should be able to get an MRI irrespective of your ability to pay. Maybe you have to wait a few hours or a week or whatnot. So I think there's a ability in a system to generate a tiered system that is fee-based, that gives people the ability to pay up for more concierge programs. In other words, not having to go to a lab, have the blood draw come to your house or things like that. But I still think the basis of our society is it is definitively cheaper to keep somebody healthy than to treat them once they're sick.
100%. And we're seeing this, and we'll get to this in law enforcement, in the fire service. You know, the proactive programs are saving these departments a lot of money. It's early days yet in the fire service because a lot of them are just switching. But when you fill the overtime spots with a straight time employee, when you have fitness standards to get people to maintain a healthy body weight, when you have access to mental health counseling, I mean, these are things that are then, emptying the bucket before it gets too full. And I think this is the conversation that people miss. If you take the NHS model, it works if you have a healthy population. And you look at Norway, you look at Sweden, Iceland, they are not an obese nation overall. And therefore, some of those more, national health leaning programs work because now those beds are full of actually sick people. They're not sick because they're obese. They're not, dying of COPD because they're all smoking, whatever. These are the preventative elements have been put in. So it's not that we need more money, more doctors, more beds. It's we need less patients. And we can do that because then if you're a healthy young person, maybe all you need is an annual physical rather than constantly be in using insurance, using doctors and nurses and, hospital spaces because, you have been in an environment where, and I always say this, with empathy. I grew up on a farm in England. The food that I ate grew in the fields or walked around the fields. Exercise was walking to the bus 3 miles to school, walking from the bus. It was cold, it was wet. So I was given an environment to understand how to live a healthy life when I was young. Now, a little boy in the bodega in the middle of New York City, totally different environment. Can't go play basketball because the gangs own that part of town. Everything I eat is fried or processed. And now, so I have been groomed in a different way. So the goal is obviously to create a national conversation in the schools and in the communities that then bolsters health. And therefore, a majority of the population isn't leaning into the healthcare system.
Right. And the other aspect, which we haven't touched on, is also the insurance companies. That is a problem. And let me explain why. We're so mobile in our insurance products. Every few years, your company is going to change insurance providers. The insurance companies know this. They're not going to pay for preventative. They're not going to pay for a preventative procedure or preventative scan, knowing that in 3 years, if I have Blue Cross, in 3 years, I'm going to switch to Aetna. Blue Cross isn't going to want to pay to save Aetna the money for the procedure. So they're looking with very short sighted goals. And if we can remove some of the private payer components and let the private payer components pay on top of a governmental system, like employing Social Security, there's the insurance companies wield so much power. They tell us what we can and cannot do, much more than what the government tells us. Medicare now, which is the primary insurance for all men and women over the age of 65, is one of our preferred insurers because they pay on time, and I don't have to do a song and dance to get paid. I don't have to ask them for permission to treat my patients the way I want to. The private insurers, it's not that simple, but the system is what it is. So there's going to have to be some changes, but it's almost impossible to get through because of all the special interests. It's hard to navigate. And let me tell you something else, and I don't want to dive into this too badly. The other problem that we have around the cost is if I went to buy a bicycle, I look at the bicycle, I don't know, $600, whatever it is. I know exactly what that bicycle is. I can decide if I can afford that bicycle right then and there. I go to the doctor says, okay, you need this procedure. Okay, how much does it cost? Well, let me check with your insurance. Well, it's going to be between $100 and $1,000. It depends on how much healthcare you utilized, where you are in your deductible, what our insurance carrier has negotiated with this provider. If you went to buy a bicycle and they said, how much is this bike? I don't know. We're going to give you the bike, but we're going to send you a bill in about 1 month to 14 months. And that bill will be either $25 or $1,000. But just take the bike now. But you have to pay us a little bit up front, but we'll come get it at some point. A lot of people are like, I don't want to do that. I don't know what this is going to cost me. But that's our healthcare market. We can't even tell people what things are going to cost them. And the other weird thing is, I had a bunch of back surgery several years ago. And I was getting an MRI on my back. And right before they turned the MRI, and the guy comes running and says, stop, don't do the procedure. Insurance hadn't approved it. At this point, I'm in a ton of pain. I'm in the MRI machine, about to get put in. I go, how much is this going to cost if I just pay cash for it? I just pay cash. $4,000. Take me out of the machine. Fine. I found it would have to go through the process to get approved. But during that process, I actually looked around and found that one of the local imaging places could do the same MRI for $500. Same test. And it all has to do with the insurance contract with that facility. So instead of spending $4,000, I could pay them $500 and get the same procedure. So the system has got inherent problems with it. But we got advantages. You can get into the doctor immediately. You don't have to wait for your hip surgery. You don't like your doctor, there's other doctors that, it's free market, it's competitive. If my patients don't get good care in good time, that's good quality, friendly, there's a bunch of other very well trained, excellent cardiologists that are also super nice people within 20 miles. There's 50 other cardiologists. So if I can't do it as well, if not better than my colleagues, I don't have business. So you have the free market competition, but again, you also have the negative component about one hospital charging literally almost 10 times more for a procedure than an imaging facility 2 miles away. It's I don't have the answers, James. All I can do is, and I don't like to do this because when I was in the military, I was really instructed and taught that when I go to my commander with a problem, have a problem, but give me solutions. Don't just otherwise you're just complaining. I'm just complaining because I don't have this.
I don't think you are, though. I think that I'm gonna challenge you on that. Simply, when I hear, "Oh, but it's complicated," people use that as dismissive. I use that as, all right, well then what are the pieces? Because, mental health. Oh, well, it's complicated. Yeah, okay. So what was it? Well, it was unaddressed childhood trauma. It was sleep deprivation. It was organizational betrayal. It was relationship problems. It was a side effect of alcohol, side effect of psych meds. Well, good. Is that all of them? Yeah. Right. Well, then let's start picking them apart. Complicated is just a bunch of things. So let's put them all on the table. And then let's start saying, okay, well, we can fix that one. This we can fix with the movement on social media. This needs to go to legislation to stop corrupt politicians taking money from large organizations. And so I think these conversations do lead to solutions. And I think then, when you look at other countries around the world, you can also say, all right, well, then who's doing it right? Who doesn't have this problem? Who doesn't go to hospital thinking, shit, I'm going to have to sell my house because I had the audacity to get cancer? And then you can start finding solutions there as well. So I find these conversations exciting because I'm not a cardiologist, with all this experience. I'm a ding-dong immigrant that became a firefighter and a paramedic, but I'm a problem solver, and whether it's, a cardiac arrest with a, 500-pound patient stuck between a shower and a toilet, or whether it's the national health system, it's all basically the same thing. All right, what is the most glaring problems and how can we pick that apart? And hearing people like you talking about, not complaining, just saying this is how it is, these are the challenges, allows other people to listen. And I think ultimately maybe create a national movement to say, hey, this isn't working. We need to do something different. We don't need more money, more drugs, more procedures. We need to do the opposite to get closer to some of these countries that are very healthy around the world and are doing it very differently.
Right, but our access is also very different. My wife's Canadian and her family has to wait months for medical care. Here, you wait days. You need a procedure. Okay, do you on Wednesday. You need an MRI. Here's an MRI. So we have tremendous advantages that the speed of care and the quality of care is excellent, but we pay for it. And there's got to be a happy medium. There's got to be, again, I don't have a solution. I have some ideas, but it's a very complex situation that has so many different components that the politicians have been trying to figure it out for years. And every time someone figures out something, you alienate and anger the other side of the spectrum. They come up with something that alienates and angers the other side. So there's and unfortunately, we've got to a political climate where you can't express differences anymore. Either it's my opinion. I remember the days where, it's not like an old man, but I remember the days where we didn't agree on something. I didn't agree. Okay, I don't know. I think we should have rigid immigration enforcement. I think the borders should be less rigid. Okay, well, at the end of the day, you want a better country. I want a better country. We have two different views. Let's talk about it because I would like to learn what you think is good and why, and I can share you what my concerns are. But we can't do that anymore. We've lost the ability of civil discourse. We can't discuss things because if you don't agree with me, James, you're wrong. And not only are you wrong, but you're killing this country because your views are that wrong. My views are right. That's never been, it's in my lifetime, it's never been so blatant that there is such a polarization that we can't even communicate. And if we can't communicate, we can't get shit done. That's the problem. And, the days of reaching across the aisle, say, you know what, I disagree with what you're saying. I respect it. I don't think it's the right answer, but you're not wrong. It's just a different opinion. We can't have that discussion. And how can we solve a healthcare crisis? How can we solve a preventative crisis? How can we solve an immigration crisis, a drug crisis, if we can't agree on even the ability to talk to each other? That's a whole, I mean, we can spend hours on this topic, but that is, we lose the ability to have civil discussion and civil disagreement. There's the problem.
When my son was young, I took a class at community college and I had to do an exam. I think it was maths. And so we were in this testing center. There was a glass window. I was the other side of the computer. And my son must have been 5, 4, right around there. And so I gave him a book and he sat on this chair while I took this math test, which I can't stand math. I'm terrible at it. And he read his book for a while and then he fell asleep. And I took the test and I came out and one of the proctors came over to me and said, I wanted to ask you something. She said, how do you discipline your child? Do you spank? What is it that you do? And I was like, no, I just simply ask him whatever he's doing at that time. Is that kind or is that unkind? Whether it's stealing another kid's toy, whether it's having a tantrum, whether it's, whatever it is. And that worked for me after the whole timeout thing that I tried for a few months and just didn't work at all. He was old enough to understand. And that was it, a simple question. And to this day, my son's 19, it's the same exact principle. And I hold that to everyone from my own child to our politicians and the people in the middle and the extremists and everyone else. What you are saying, is it kind? And you could also add, is it for the betterment of the entire United States of America? Or is it not? And if healthcare policy is making people fatter, sicker, and more vulnerable to disease, is that kind or is that unkind? In a fitness standard, in law enforcement or fire, is it kind or is it unkind? Oh, well, you're trying to take a job. No. Is it kind or is it unkind? Does it increase the level of performance and does it lesser the chance of heart attacks and suicide and addiction and autoimmune disease and strokes and divorces? Or does it make everything worse? No, it makes it better. And that is what we've got to come down to. The arresting addicts, is that kind or is it unkind? Someone who's drowning in self-disgust and self-loathing and guilt and shame, that you call them a criminal, you give them a criminal record, you lock them in a box with other people that are going through the same stuff. Is that gonna make someone heal? So I think we've lost our way to answering the most simple question. Is it kind or is it unkind? Does it benefit the nation as a whole or is it a detriment? And if we can get off our blue and red little, boxes that some people, the sword they'll die on, and just focus on the nation itself and ask those questions. Is it making us healthier? Is it improving our mental health? Are our schools safer? Are our borders secure, but we're allowing people to come in just like we have for 250 years, that middle ground? Then I think you're in the right place. But if you're dying on a hill that's an extreme at the detriment of your own country that you claim to care so much about, I think that's the disconnect.
Yeah, but the problem in that is that everybody would potentially define kindness differently. So I hear what you're saying. I look at it though is, again, I have to have, if you and I disagree on something, I have to have enough respect for you to hear what you have to say. And if I don't agree with you, maybe I can agree with a portion of what you're saying. Because at the end of the day, you want the same thing I do, a better place to live. You may be coming at it from a different perspective because of your background. I may be coming at a different perspective, but to me, someone can say, well, we want 100% board. That's the kind thing to do. And other people go, no, the kind thing is to not let people through. So it's got to be, for me, it's the way you define the terms is not as important as being able to have a conversation. The fact that you can have two people who are completely different when it comes to any kind of critical decision, and if you can come to some kind of discourse, okay, you know what, James, I disagree with that, but you're an intelligent person. I can see where it's coming from. I never thought of it from that perspective. How about we find a area that's compromised for both of us? Or, okay, I'm not willing to die on that hill, but would you look at this from my perspective and would you consider giving me this component? Okay, John, that's reasonable. So that's my concern. We don't have the ability to do that. We can't talk about religion. We can't talk about borders. We can't talk about abortion. We can't talk about politics. We can't talk about Social Security. We can't talk about healthcare because everybody is so stuck in their own place that I can't even see yours. And that, I think, is a problem. Again, I'm not a politician. I'm not an expert on these things. This is purely my opinion, and I don't get asked these questions on a regular basis. So hopefully my answers are coming off, somewhat not completely ill-informed, but, you're getting down to some personal questions, which, these are all my own thoughts and opinions.
Well, what kills me is people say, oh, that's politics. Like, what, the health of the nation is politics? The addiction crisis? No, it's not. This is caring about the people in your country. So people, I think, label things politics so you don't talk about them. And I think, this kind of discourse is what we need. So then we can start unpacking all of the things. And I'll put one more thing and I want to go to a different direction. But the other thing that worries me is I think that the inability to communicate is also a red flag of the national mental health crisis. I really do. You look at COVID, friendships and families were ripped apart because you did or didn't strap a cloth mask to your face, or you did or didn't have a vaccine, or you did or didn't believe that it was a Chinese conspiracy or whatever the thing is, rather than the critical thinking that happens in a healthy, well-rested mind, which is the middle. Well, it's clearly a real disease because people around us are dying. But, the wellness of the people seems to be very important too. And N95 works if you secure it properly and you test it and use it once. But your grandmother knitted you probably isn't going to work. You know what I mean? So the ability to, just like you said, meet in the middle, I think the struggle is because people are overworked, underslept, stressed out by Fox or CNN. And so we've created this kind of chaos in a lot of people's minds. And so they just cling on to this extreme left or extreme right as their kind of tribe of safety rather than actually feeling comfortable enough to go to the middle.
100%. I think two things along that line, and then we can pivot. But number one is the more radical one side gets, polarizes the other side.
100%.
So it's a self-fulfilling prophecy. And the other thing is we're spoon-fed. We no longer have Walter Cronkite to tell us this is what happened, make your own opinion. You have news medias, which are incredibly slanted, either incredibly conservative, incredibly progressive, or liberal, and they deliver the news in accordance to what their followers want to see. And now we're at the point, that's not even real news. That's fake news. That's not real news. Well, it is real news, but it's a different perspective, So I agree. There's no room for radicalism. There's room for conversation across the entire spectrum. And if we're able to do that, and I'm hoping our kids will be able to do that, there's the answer, my friend, is just be able to disagree and still come to a reasonable conclusion that's better for everybody, the way it used to be.
100%. I think this is what I love about podcasts is that two people, 3, 4, whatever it is, if it's one that's actually, trying to bring solutions to problems, can have a conversation, and then person C is listening, driving, running, working out, walking the dog, whatever, and they can't interrupt, and they come, oh yeah, but and then, if you have hopefully a good host, which I hope I am, to shut the hell up and let the person complete their thought process, then you're like, oh, actually, I'd never thought of it that way. So I think this medium, documentaries, some of the great things that you're seeing out there are actually bringing conversation back if you look at it. Now, don't get me wrong, there's the Manosphere podcast and all those that are doing a lot of damage, but this medium and some of the great journalism that's still out there on television, that is what people need more. But as you said, those are the very things that are being censored by the people that just want you to listen to their propaganda machines on the left and the right, So with that being said, I want to pivot one thing that you said earlier, and then we'll go back to, I want to talk about the Middle East for a moment. Not even functional, excuse me, that's the name of one of the companies. Preventative MRIs, full body MRI scans. I see a lot of value in those in the first responder profession, especially if you can do it from day one, brand new cadet, and then you can then track the progress and see any changes. What is your perspective of that as a preventative diagnostic tool?
I'm going to respectfully disagree with you.
Oh, please.
I don't think they're good tools.
Please.
And I'll explain why. In order to test for something that is useful, what you're testing for has to be present in the population at a level that's concerning. So let me give you an example. This is a cardiology example of a bigger question that you're asking. When it comes to screening people, now again, my company, my experience, my publications is basically law enforcement. It's not fire service. The fire service has a completely different set of exposures, toxic chemicals, heavy metals. It's a different world. But I'll give you an example. We know in law enforcement, heart disease is the number one killer. Okay. There are companies that will go out and they will do full body ultrasounds. Ultrasound the thyroid, ultrasound the abdomen, ultrasound I'm looking for an abdominal aneurysm, ultrasound the heart with echocardiogram, looking to find abnormalities. But if you look at that data, none of that stuff causes heart attack. So if someone has a heart attack, it's a coronary artery inflammatory process. And we can talk about the pathophysiology, but for example, to pay someone to come in and do a thyroid ultrasound and an abdominal ultrasound looking for an aneurysm, the aneurysm rate on people over the age of 65, which is what we screen now, is 0.6% over the age of 65. There's no cops out there over the age of 65 that have abdominal aortic aneurysms. So screening for something that's not prevalent is useless. And let me pivot onto sort of another example. Years ago, we used to do chest x-rays for a standard physical exam. Everyone would come in. Now, I'm not talking special populations. So I'm not talking about the fires. I'm going to come back and answer your question a little bit more specifically. But we stopped doing regular chest x-rays because these numbers are not accurate. I'm just using these numbers as an example. Let's say we do 1,000 chest x-rays and we find 100 abnormalities. Okay, that's 100 people who need to have a CT scan. And again, these numbers are not accurate. I'm just giving them an example. Out of those 100 people get CT scans, we find 25 abnormalities that are confirmed. Those 25 people have to get biopsies. Out of those 25 people, you have 2 complications. It's not that prevalent, but again, this is just for argumentative sake. So out of the cost of screening 1,000 people, you created 2 complications. That could be death, it could be an infection, whatever. You end up causing more problems on those people you screened than what you saved in cancer. So if you screen 50,000 people, you're going to cause 100 complications and maybe only save 5 people from cancer. So the reality is what you're screening for has to be prevalent enough in the population to justify the screening. This is one of the tenets of screening. So if you screen for something that's not prevalent, you're going to find weird anecdotal things. Now, this is different than saying, I had that full body MRI, and if I didn't have that, they would not have found that small, tiny lesion on my kidney, which was kidney cancer, and they were able to take it out. That's not science. That's an anecdotal testimonial. That is an experience that one person had. But when you extrapolate it over the course of a larger population, you end up getting information that's not helpful. In fact, some of the screening tools hurt people when you look at the population. This is why we don't do screening chest x-rays anymore. Now, if you focus the screening on a population that has a specific problem, you're changing the game. So firefighters have number one killer of firefighters is still not cancer, it's heart attack. There's ways to prevent heart attack. I published papers on this. We've identified the specific ways of looking for heart disease in law enforcement. It happens to be the number one killer of firefighters. We know how to do it in that regard as well. But firefighters also have a higher incidence of cancer. So is cancer screening warranted? And if so, what cancers are prevalent? How do you screen for them? It's not an across the board. So when it comes to doing a full body scan on standard regular people, we end up spending money, creating problems, and we don't find a statistically significant change. Now, this is different if, like I said, if you're that one person they found and you found your pancreatic tumor or your kidney tumor. But when you extrapolate to a population, it doesn't work. So what I'm simply saying is the screening tools have to be safe and effective, and what you're screening for has to be prevalent to such a degree that it's worth screening for.
I mean, it's fascinating to hear your response. And from the law enforcement side, I agree even more. What's terrifying about the fire service, and I've said this phrase many times, is we don't die of one thing, we die of everything. So yes, cardiovascular issues are definitely, one of the big ones. I think cancer actually outweighs cardiac, if I'm not mistaken. And sadly, and the same in law enforcement, suicide blows all those numbers away,
No,
times two.
that's not accurate. Heart disease is the number one killer of firefighters and cops. Suicide is, believe it or not, a small killer, but they're lightning strikes. So if you look at the data, let's actually start generally. Heart disease kills more people in the United States than anything else. It's the number one killer across the board. Within that, firefighters and police officers die from heart disease more frequently at younger ages. So it's the number one killer in both those populations. And when you compare it to the general population, the average age of a cop with a heart attack in the U.S. is 46 compared to 65 in the civilian sector. Cops have a 22-year life expectancy, which is lower than the general population. Huge differences. Firefighters also, the number one killer is not suicide or cancer, it's heart disease. Cancer second. So these numbers have been, this is in my opinion, this is data. And then if you look at the companies or the organizations that track death, and again, I'm going to speak as a law enforcement officer and someone who has a huge degree of experience in law enforcement wellness initiatives. If you look at heart disease, it's easy to identify, it's cheap to identify, and it's so preventative. If you don't look for it, it's a problem. So in the world of law enforcement, when you look at the agencies that track heart disease, we track deaths. We don't track illness. We don't track the number of heart attacks. We track the number of people who die from heart attacks. That is fundamentally flawed in two different ways. Only 3% of heart attacks are fatal. So 97% of heart attacks that occur are not counted. And the organizations like the National ODMP, the Officer Down Memorial Page, they track line of duty deaths. So if you get off work at 4 p.m. and your heart attack occurs at 6 p.m., it's not counted. If you have a heart attack and you're even working and it doesn't kill you, it's not counted. So we're missing 50% of the heart attacks that happen on those other 12 hours that I'm not on shift. And we're missing 97% of heart attacks that don't kill people. So when you extrapolate, the heart attack becomes the number one source of morbidity and mortality in both firefighters and law enforcement. It's just skewed the way we calculate the data. So screening for things that are prevalent, you get the most juice for your squeeze if you focus on heart disease. Now, again, I'm not an oncologist. I know cancer is a huge a huge factor in the fire service. But within cancer, as you know, there's multiple types of cancer and there's a gazillion different ways of testing for it. So you've got to find that the screening has to be done appropriately. That's really what I'm getting at. And again, as someone who doesn't treat cancer, doesn't screen for cancer, I'm not really the expert on how to do it, but I can tell you sure as hell how to screen for heart disease and how we find it and how we prevent it in the public safety arena. But it's not as simple as a full body scan.
When you talk about the statistics, not only have you got the, what is classified as line of duty, but also in the mental health side, you've got the shame, the guilt, the stigma. So whether it's people not reporting that was actually a suicide, whether they're ignoring the single vehicle wrecks into a freeway bridge, whether it's the addiction, the overdose, the alcohol related elements. And then I think another thing that screws both of our professions, and it really nauseates me, is in the VA, it's not perfect, but you're still counting people after they've taken the uniform off. There is no VA for police and fire. So the moment you or I step outside a police station or a fire station for the last time, you drop dead a week later, you're not a statistic. So the shortened lifespan of first responders would blow these numbers out the water. And I wish we had those so you could really see the detrimental effects of the wrong way of working our first responders.
Yeah, I agree 100%. You're right. But we do know also that heart disease, once a cop retires, heart disease is still the number one killer for many years. So we see it. In fact, there's a lot of statistics published on the average life expectancy after a cop retires based on payment. Now, I actually compared some of these in a paper I wrote back in March of 05 or 04. I can't remember the year I did it, but it varies depending on this. California has certain data, and Buffalo, New York has other data. But you're absolutely right. This is not a problem that simply disappears when someone takes off the uniform.
You sent me a paper that you wrote as far as a very effective screening tool. We heard about calcium scores. Obviously, we've got, stress tests, some other things. What are you seeing now as the gold standard for screening for heart disease in law enforcement and ultimately other first responder professions as well?
This is my favorite question, James, because this is my career. This is what I spend my time on. In order to answer your question, you've got to understand the pathophysiology of what a heart attack is. A heart attack, of course, is a blocked blood vessel in the heart. But when those blood vessels block, it's not an artery that would go from 20% to 40% to 80% to 90, 99 heart attack. So it's not a linear or even an exponential progression of plaque deposition. What you have is as we form plaque, people don't realize we form plaque in the arteries, not inside the opening of the artery, which we call the lumen. So development of plaque is not like scale in a pipe. The plaque occurs inside the wall of the blood vessel. So the cholesterol particles penetrate the wall and fill the wall of the blood vessel. That causes the blood vessel to narrow, but more importantly, it causes the blood vessel to get inflamed. And eventually that inflammation is so severe that the retained plaque in that wall bursts. It rips through the wall of the blood vessel. All that fatty plaque extrudes or spills abruptly into the opening of the blood vessel where it mixes with the blood and a clot forms. That's a heart attack. You go from an artery that's not obstructive to an artery that's 100% obstructive rather abruptly. Knowing that this is the process, we now have solid data that there are markers of inflammation that rise in the blood before plaque becomes ruptured, before plaque ruptures. We have what's called vulnerable plaque. And as that inflammation is building in the plaque itself is releasing chemicals into the blood. Some of those chemicals are known as oxidized LDL or PLA2, phospholipase A2. And these markers have been shown to be independent predictors of heart attacks. In other words, independent of age, gender, tobacco use, cholesterol levels, blood pressure, diabetes, before someone has, again, there's no 100%. One of the wonderful things and terrible things about medicine, there's never a never and there's never an always. It is always degrees. But almost 100% of the time, heart attacks are able to be predicted by looking at markers of inflammation. In fact, we published a study, which is what you're referring to. We took what will be considered standard risk analysis. Standard risk analysis, if you come to see a doctor, and they look at you and they look at your age, gender, blood pressure levels, cholesterol levels, whether you're a smoker or diabetic, and feed it into an equation. And that equation comes out and basically tells us whether you're low or high risk for heart disease. That's called a Framingham or ASCVD score. That type of scoring works really decently for civilians. In other words, if you score civilians, 75% of civilians who are at high risk will be identified with that test. You'll miss a quarter, but from a screening standpoint, that's not bad. However, when you apply that screening to police officers, it misses 92% of cops that are high risk. 92% of cops don't have enough traditional risk factors that they will become high risk on those tests. What works is measuring these inflammatory markers. And these inflammatory markers, so this inflammation in the artery is much higher and much more frequently seen in law enforcement than it is in the civilian sector. So then the question, of course, is why is this? Is it because, and we first set out this article, we didn't know, is it because cops have higher levels of high blood pressure, high cholesterol, diabetes, smoking? Or if everything is held constant, if you look at two groups of people that are basically the same gender, same age, same levels of cholesterol, same blood pressure readings, same smoking status, if everything is pretty well matched, do cops still have higher heart disease? And the answer is yes. So it's not a function of worse cholesterol. It's not a function of higher smoking. What we believe it to be is a function inherent in the job, which is a stress pattern. So let me actually tell you this way. I travel all over the country and speak on this, and people go, oh yeah, cops are stressed. That's what this is. And my response to them is everybody's stressed. Everybody, I think you mentioned your ex. I mean, I have an ex-wife, marriage is stressful. Kids are stressful. Money, I don't care. I see people every day in every aspect in my practice with different financial levels. I don't care how much money you make, money is stressful. There's no question. I had a patient who he was having chest pain because he has a portfolio worth hundreds of millions of dollars. He lost $50 million in a transaction. All right, I would like that problem, but it was terrible for him. So money is stressful. So everybody's stressed out. But the issue with police officers is that it's not the amount of stress, it's the pattern of stress. And you know this as a firefighter, as a paramedic, but unless you put a badge on, people don't realize that being a cop or being in the public safety sector is a boring job until it's not. So you have these long periods of patrol or paperwork or routine investigation punctuated by these rapid drops of adrenaline. We call it 98% boredom, 2% terror. So you're sitting along, all of a sudden, explosion of adrenaline, quiet, explosion of adrenaline. And we see these on a regular basis. And it extends throughout someone's career, regardless if they're a patrol officer in a small town, a beat patrol officer in a city, a highway patrolman, a detective. It's the same pattern. And it is believed that these bursts of adrenaline, which create a whole bunch of physiological changes, increase the inflammatory process in those arteries. And that's why we see heart disease, because when you control for everything else, in my study, interestingly, we compared civilians to law enforcement officers. The civilians actually smoked more and were older, and yet the law enforcement officers still had more inflammation in the arteries. So we believe it's inherent in the profession. Now, it doesn't mean it has to be this way, because if you know what to look for, you can identify it by looking at these inflammatory markers. And if you can identify it, you can treat it. So again, to go back to sort of put this right back to where you started with this, is you have a situation in which you have a condition that is very prevalent. You have a screening tool that is very safe and effective, and a treatment that can take the screening tool and convert it to a measurable outcome. If we could just screen people for heart disease, and at the end of the day, we say, okay, these people are at risk, well, what do we do? Really nothing. What's the point of screening? You have to be able to intervene on that person to create a problem. And we're lucky enough to be able to find these surrogate markers, like these inflammatory markers. The best one ever published is something marker called LPPLA2, or phospholipase A2. It's a surrogate for a heart attack, because this rises before a heart attack. To take what you said earlier about suicide, the biggest problem we have with suicide is we don't have a surrogate. We don't know. I'll give you an example. We don't know that, okay, this agency at some town creates a peer mentoring program. They come back and go, we haven't had a suicide in 5 years. Well, I can always say, well, you haven't had a rattlesnake attack in 5 years either. So your peer support program is 100% effective at preventing rattlesnake attacks. So you've got to look at, and so you have to have a prevalence of a problem which is high enough that you can use your intervention to see if the statistical changes are more than what you see in chance and chance alone. And the problem with suicide is we don't have that. We don't have surrogate markers. We think we may. It could be use of force more so than standard, absenteeism, civilian complaints. So there's a bunch of things that indicate bad behavior or higher risk, but no one has come up with a scoring tool that says this is how we can reduce these things, we can reduce suicide. But we have that with cardiovascular disease.
What does the test look like, and what are the interventions that you would suggest if a positive result is obtained?
The test that we do for coronary disease in law enforcement is simply blood tests. That's it. It's not imaging. It's a blood test, and it's a rather cheap blood test. So I come forth in today's talk with my one mission, and that is to bring awareness. Because if you know what I need people, and I hate this word because it's been bastardized over the years and overused, but I hate the word empower, because when you empower it's gotten it's a bad word. It doesn't mean anything. But what I like to say is I want people to be aware and educated and know what to ask for. The way we get this testing done is very simple. There's companies out there that do it. Now, I have a company, and I'm not here to promote that company, but I have a company that does this exclusively. Or I want to empower, and again, I hate that word, for the line officer to be able to go to his or her physician and go, this is the test that I need. And I know this test in published peer-reviewed data has been shown to identify heart disease in law enforcement more so than what we would see in any other screening test. The test I'm really referring to is phospholipase A2, LP-PLA2. And that test is not an expensive test. So if the department won't engage with companies that will run this test, the individual officers have to take it their responsibility to find it themselves. I use the example of when you buy a car, you're going to look at, I just bought a truck this year. I looked at Ford, the F-150s, I looked at the Chevys, I looked at the GMCs, I ended up getting a Ram. And then after I found the truck I wanted to get, I looked at 3 different dealerships. This one's closer, this one gets free oil changes, So I did research, and then I picked the dealer and I bought the car. A lot of people don't do that when it comes to their doctors. They walk in the doctor's office, oh, you're my doctor? Okay, thank you. They don't advocate for themselves. So the individuals, I would urge your listeners to advocate. If you're a firefighter, if you're a public safety worker, if you're a police officer, EMS worker, a dispatcher, this is the problem that we have. If we believe it exists in jailers too, never been determined, never been studied, but we believe it exists. And that's one of the things that we're working on in our company is trying to get the jailers screened so we can come up with data for them. But to go to your doctor and say, look, I'm a police officer. I know that my average age of a heart attack is 46. I'm 44. I feel great. I work out, but I want this test done. And if the doctor goes, I don't know what that is, then you got to find another doctor. So that's the first thing. The second thing is, what do you do about it? It's a beautifully easy fix. It's a 3-pronged approach. It's the right medication, it's the right lifestyle, and the right nutrition. If you do that, you obliterate it. Now, there are people out there that go, I don't want to take a medicine. But unfortunately, the cholesterol medicines are the only tool we have that has ever been shown to cause plaque to stop forming and begin to regress. Cholesterol is not a diet problem. It is not an exercise problem. You can't eat your way into or out of a cholesterol problem. Crappy lifestyle makes an otherwise bad problem worse. A healthy lifestyle mitigates it. But if someone has plaque forming, and that can be demonstrated in multiple ways, that person without question needs a cholesterol medicine. But you can't take a cholesterol medicine, sit on the couch and do nothing. Just the same way if you have plaque, you can't be a paleo or vegan triathlete and not take the medicine. So the first arm of therapy is the right cholesterol lowering medication. These medications are safe. They do not, will emphasize this to your listeners, they do not cause the problems that people are afraid of. These medicines do not cause dementia. The chance of these medicines affecting liver is less than 1 in 10,000. About 4 or 5% of people who take cholesterol medicines don't feel well on them. If that's the case, we simply stop it and we choose a different medicine. But that has to be paired with a healthy lifestyle, which is diet, exercise, pattern changes. We've got to eat healthy. In law enforcement, you have an environment where you don't have, you're running calls all day long. You're starving. You're going to go to McDonald's because it's quick. It doesn't work. Your sleep cycles are terrible. We don't hold these people accountable. You mentioned multiple times in the conversation fitness assessments. We have to hold people accountable to a fitness standard. So if you have the right diet and exercise patterns, and just for your audience, I'm a huge believer in the paleo diet, which is basically fruits, vegetables, and meat. You eat the way that you described on a farm. Our grandparents used to eat. Nothing on the shelves of the supermarket, nothing processed. Fresh fruit, fresh vegetables, and unprocessed meat. Dietary fat doesn't cause a problem. What causes a problem is all the artificial stuff that lines the shelves of the supermarket. You avoid the shelves, eat the periphery of the supermarket. You have that, and plus you exercise regularly. And if you do that and you have the right medicine, you're there. Now, the last component I'll mention is there's certain things that are scientifically proven with evidence-based studies to reduce risk even further. For example, fish oil. In fish oil, there are 3 particular ingredients: EPA, DPA, and DHA. EPA, Echo Papa Alpha, which is also called icosapent ethyl, has been shown in multiple trials to reduce cardiac events by up to 25%. So in other words, There's one trial called the JELIS trial. They took 8,179 people, all who had some degree of plaque forming. Half got a placebo, the half got pure icosapent ethyl, and the people who got the fish oil, after year 1, the curves diverged, and by years 3, 4, and 5, there was a 25% additional reduction of heart attack and stroke. That's science. That's exactly the opposite, for example, of a multivitamin. A multivitamin has never been shown to do anything. I got plenty of people who come, oh my God, these multivitamins give me more energy, or I sleep better, I have better erections. You name it. Supplements have been, but that's anecdote. That's not science. CoQ10, another big one, never been shown to do anything. I have patients who swear by it. I take this medicine, I have more energy, less muscle pain. Great. That's not science. But there's a few things. So folic acid, which is vitamin B9, EPA fish oil, treating an abnormal gut biome with probiotics, those things have been definitively shown to reduce coronary disease. So if you use the right medication, the right lifestyle, and you supplement these things that are found to be deficient, we knock it out of the park. We can identify people who are at risk, and we can treat them and mitigate that risk. Easy to do.
You talked about cholesterol, and I want to get your take on this. When you've got this positive blood test and you're looking at, LDL levels, whatever the other elements are, and you're recommending Lipitor, one of the similar medications, that obviously now is trying to reverse what you've already seen as a disease process that is advanced. I have seen in the fire service, knowing as well, and I'll get to shift work in a second, how much sleep deprivation disrupts the endocrine system. Young, healthy firefighters that are on statins when they're in their 20s, their blood pressure is good, they got no cardiac issues at all. There's a lot of obviously misunderstanding and mythology around the word cholesterol. Talk to me about, if it's someone with no other factors at all, just a higher cholesterol level in a blood test, where is the facts as far as, some of these blood tests and maybe underlying other conditions? And is that information being interpreted incorrectly sometimes with otherwise healthy individuals?
That's the best question you've asked all day, because you're absolutely right. There's a lot of misconceptions. Let me tell you how we, in the cutting edge world of preventative cardiology, how we look at cholesterol. I don't care what someone's cholesterol is. It's irrelevant. What I care about is whether he or she is forming plaque. Now, the majority of us, as we get to be in our 40s, 50s, and 60s, if you have abnormalities in your cholesterol, you will begin to form plaque in the arteries. But there are people out there that have cholesterol that is literally off the charts, yet do not form plaque. We can talk about why that is or whatnot, but there's people that have cholesterol that you look at their numbers and you're like, wow, this is a disaster. But when you look at that person, whether you look at inflammatory markers, coronary calcium, ultrasound of the carotid arteries where you can actually visualize plaque, or there's a host of ways of measuring plaque, they have no plaque. When you have no plaque, you do not benefit from cholesterol-lowering medication. Okay. However, on the other side of the coin, I have plenty of people I see on a regular basis who've been told their whole lives that their cholesterol is normal or low or perfect, and they have plaque forming, they have blockages, they've had heart attacks. That group benefits from cholesterol medication, even if their cholesterol is normal. So it's not as simple as, okay, you're 25 years old, here's what your cholesterol needs to be based on your blood pressure, diabetes. That screening tool, which looks at blood pressure, cholesterol, sugars, diabetes, and such, doesn't work. We look for individual. We look at individuals. I don't look at populations. So if I'm looking at someone and they are forming plaque, irrespective of their cholesterol, the only tool that has ever been shown to reverse that plaque and cause the plaque to begin to diminish are cholesterol medicines. But if there's no plaque, there's no indication for cholesterol medicine. And I will tell you, we know back from studies going back to Vietnam that these young soldiers, 18 to 22 years old, who were killed in Vietnam, 50,000, a lot of autopsies. We know plaque starts in our 20s. This is a process that starts early. It takes decades to manifest. So if you're in a career that has a high risk of coronary disease, for whatever the reason, and you detect plaque, that plaque needs to be treated. But again, it's not a cholesterol number. So when you look at cholesterol, cholesterol is a vital component of cell membranes, hormones. So cholesterol is not inherently bad. It's just a risk factor. But there's some people, so standard, you mentioned LDL, which is the bad cholesterol. The problem with measuring LDL is not all LDL is the same. LDL has been identified in 7 different subclasses, 7 different sizes. Think of LDL as existing as golf balls or beach balls. The small, dense particles are able to penetrate the endothelial lining and accumulate inside the wall of the blood vessel. The large, buoyant beach ball LDLs can't. So just looking at sheer concentration of LDL is misleading. We have to look at the particle size and the particle density and the particle number. That's what drives events, not just LDL concentration. And there's several ways of measuring that. There's several different buzzwords, ApoB, you can measure non-HDL cholesterol, you can measure particle number. There's so many ways of doing it, but at the end of the day, you're measuring the same thing. You're measuring size. I also like to add, again, we no longer use a one-size-fits-all approach. So if you and your identical twin brother had identical cholesterol patterns, one of you may have no plaque and one of you may have had a massive heart attack. There's so many other variables that it has to be done individually. So I propose and I push forth the concept. I don't care what your cholesterol is, James. I care whether you're forming plaque. And I can't look at your biometrics, your abdominal waist, your blood pressure, your cholesterol levels, your diabetes. Now I can look at those and get, I think you're going to have plaque. But every time we do it, we get surprised. I have brittle diabetics that are smokers, and we take them to the cath lab. They have the most beautiful arteries you've ever seen. And I got vegans who are marathon runners who have massive heart attacks. So I get an idea of what's going on, but when you get into the public safety arena, the whole thing is skewed. So I don't look at cholesterol per se. I look for the presence of plaque, and I treat the plaque very aggressively.
I'm so glad I asked that question. That was an amazing response. So thank you. One
That's
more area.
Brilliant question. Yeah.
One more area before we just quickly talk about your time in the Middle East. I want to make sure we discuss that as well. You talk about flogging a dead horse. I've flogged a field of dead horses when it comes to shift work and all the ill health that comes from it, the physical health, the mental health. And what's beautiful now, again, we're talking about problems and solutions, picking that problem apart. We have caused a revolution that started here in Florida and is sweeping across the country now, giving firefighters more rest and recovery. And I would imagine that Austin and San Antonio and all the places around you are working 56-hour work weeks, 24 on, 48 off. And then probably they have a recruitment and retention problem at the moment. I'm sure people listening are probably nodding their heads. And now there's either voluntary and or mandatory overtime, turning that into an 80-hour work week, not sleeping 4 nights. And we're seeing that. And when I started this podcast, it was because I heard someone talking about sleep medicine, and I dove into it, and I'm hearing about everything from the hormonal disruption and, how many firefighters you ask, what is your testosterone, and it's in the toilet and they're only 25, through to, the direct correlation between sleep deprivation and suicide, addiction, depression, anxiety, so all the things. And so a beautiful proactive solution that also is fiscally responsible is front loading the money, investing in more firefighters and therefore more rest and recovery, and diminishing the chronic disease, improving the performance. What are you seeing when you're researching, again, another shift population? And obviously they're not able to do 24-hour shifts. So it's usually, 12s or 10s or 8s sometimes. The impact of that shift work on the health of your law enforcement men and women.
No question. It's brutal. Shift work has been associated, changing shift work and midnight shifts have been associated with increased risk of heart disease. We know sleeping is vital. And you're absolutely right. Austin is understaffed. Austin, for the size of the city, should have 2,500 cops, patrol officers. We have 1,000 less than that. The detectives are being pulled off investigative work, even the homicide detectives, to pull call and to pull patrol shifts. And let me tell you, patrol is a perishable skill. If you've been a detective for 10 years, you don't know how to use the new electronic ticket writers. Your spider sense dulls a little bit. I mean, it's a perishable skill. So when you're understaffed, you're working more frequently and more hours. And then, because it's so lucrative to pull overtime assignments at jewelry stores and malls and whatnot, that despite working the shift, you're going to pull these overtime assignments because you want to make more money for your family. So it's a terrible thing. So being in public safety now, not only do you have the increased adrenaline, it's a perfect storm. You have increased adrenaline dumps. You have sleep deprivation, which we know is catastrophic. You have a diet of convenience. So you throw on top of this, I don't have time. I didn't prepare my lunch today. I'm just going to McDonald's. I get a burger, fries, Coke, fuck it. I'll get whatever I want. That's a problem. You put all these things together, it's a perfect storm. And that's why we see heart disease as the number one killer. But you're right. It is a situation that also is significantly impacts and is impacted by retention and recruitment. When we talk about retention, I always look at this. You take a young cop, just get out of the academy, 22 years old, typically, the best physical shape of his or her life. They've undergone either thorough or even rudimentary psychological screening. So they're not completely crazy. You may miss people and there may be personality disorders, but they've more so than just about any other job. So you take this young person at the peak physical and mental health. You drive them through a career to average about 23 years, and you kick them out at the end 23 years later. Now they have a higher risk of heart attack. They're obese, more likely to be diabetic. You've given them a 22-year life expectancy less than the general population. You give them a higher rate of alcohol abuse, substance abuse, divorce, and suicide. So you take this phenomenal, healthy resource and you destroy it over 23 years and you kick it out and they live 5 years before they die. Is that the way to recruit people to our business? No, it doesn't work. You've got to institute a program of wellness, and that can be defined on so many different levels: psychological wellness, financial wellness, spiritual wellness, physical wellness, that you cannot take these young kids and destroy this raw material. You've got to be able to provide the right support so they make it through their career and then can enjoy either a second career or a retirement for giving so much of themselves, so much selfless service that they've earned it. They've earned it. They spent the time away from their families on birthdays. They work Christmas. They work New Year's. They work Thanksgiving. They're exposed to trauma that people shouldn't see. Dogs lit on fire, domestic abuse, horrible collisions. And then we give these people such a increased risk of morbidity and mortality. It doesn't have to be this way. It is the command staffs, not only is it their obligation, but it's their moral, absolute moral conviction. They have to make sure we take care of ourselves, our troops. And it's more than just wearing a body armor policy or having a reflective vest policy or pursuit policy. We've got to hold these people accountable, whether it's a carrot or a stick. Here's a physical standard. Here's mental health resources that you're not stigmatized for using. Here's financial advice so you don't get all your money and blow it on a car every year. So we have to take care of our folks. And if we don't, and then we wonder why we can't get cops, why we wonder we have a shortage. Well, I wouldn't enter a profession if I knew in 23 years I'm going to have a higher risk of obesity, suicide, diabetes, heart attack, divorce, substance abuse, and alcoholism. What the hell? I'm not doing that. So there's what we're faced with.
I mean, you could have literally been talking about the fire service. And it's so crazy because I know in fire, at least, I don't think there actually is a study that officially says we die 5 years within, after retirement. But it is, you ask anyone on each corner of the United States of America, they will tell you the same thing. And to your point, you just literally described this. That's not even the average citizen. You're talking about a fit, mentally resilient man or woman that toes the line on day one, who arguably should have an even longer lifespan.
Yep.
And I think that this is what's exciting to me, because if you frame it not in, oh, they keep dying, let's get them to die less, which is the law enforcement and fire conversation, but frame it in the ocean lifeguard, the NFL player, the tier one operator. We want them to operate at the highest level. Now you've shifted the idea. Well, of course, then you need fitness standards. If we're going to look at it that way, if you want them to climb 30 stories with 100 pounds of gear before they get to the fire, then yeah, they need to be fit. They need to have a clear mind. So we need breath work. We need meditation. We need counselors. We need fitness standards. We need, rest and recovery. Now you've shifted it. And I think what is exciting to me about this beginning of this revolution in the fire service, and shift work isn't the only thing, but it's a massive piece of the puzzle, is when you give them more rest and recovery, you attract young men and women. Then let's say you layer that with a fitness standard. You're like, okay, we've not done this before, but we care about your longevity and your performance. So you were fit when you walked through a door. All we're asking you is to stay fit. That's it. We're not saying you come in at 400 pounds and we challenge you to lose 300 in a year. We're just saying hold the line. And now now you're forging a long and healthy retirement as well as a high performing career. What's interesting, and I'd love to get your take on this, is occasionally people will say, well, what do you do for the 12-hour people? And I'm talking about fire. So fire service should be doing 24. We have a house called a firehouse with beds. That's what works for us. But for law enforcement, for the ER, for these other places, corrections, what you see with shift work is, well, John, you're going to work nights, so I'm going to pay you $4 an hour more. That doesn't give you any more rest and recovery. It doesn't offset the extra stress that you've had working through the night when Steve gets paid $4 less, but he works, 8A to 8P. So my thing is, if we know the corporate space is leaning towards a 4-day work week in a lot of places in the world with a high level of efficacy, and they're not working shift work, it would be interesting to say, all right, well then same salary. If you are a day shift, you get $80,000 a year. If you're a night shift, you get $80,000 a year. Day shift works a 40-hour week. Night shift works a 32-hour week. So you get an extra period of rest and recovery in lieu of the fact that you are going to be working overnight. We're not going to bounce day and night. You're going to be on nights for a period so that you're not messing up your circadian rhythm. But in return, for you being awake when the rest of us are asleep, we're going to give you an extra 12 hours to recover. That seems to me the only logical solution for your community and a lot of the other ones that work the 12s.
It's brilliant. The only problem is when you're understaffed, you can't do it. In a perfect world, it's brilliant. I think it's a great idea. The other thing in a perfect world is you can have the people the choice. You know what? Often they're not given a choice. You're a new patrol sergeant, you're going on nights. You're a new lieutenant, you're going on nights. You just got out of your FTO program, you're going on nights. Oh, I get extra $4, okay, but it wasn't my choice. So it's not that simple. The simple thing is, in theory, it makes great sense. But if we're talking 20 minutes for a hotshot call for gunshots fired, it's 20 minutes to get a cop out there, they're not going to give you an extra 8 hours off because they can't afford to split. They can't afford to have those bodies off the street. So that comes down to recruitment and retention. And our environment right now is terrible. And it's not just the physical, it's not just the things that I said. Our environment also includes, and again, this is getting political, but here in Austin, which is a rather liberal, progressive city, we have a district attorney who was elected by the populace to specifically make sure cops do not violate certain standards. So we have, in the law enforcement perception, we have a district attorney who over prosecutes cops for doing things that they were trained to do. The other side of the coin is they look at the district attorney and they say, well, he's doing what we elected him to do. But we have cops that are afraid to do their job because they don't want to go to jail. And now I'm not talking about the grossly negligent cop that shows up intoxicated and shoots someone in the back as they're running away. I'm talking about a cop that is following his or her training, literally, and still gets indicted by a grand jury for a homicide. So we have that environment. So you throw that in on top of the things that I mentioned earlier about taking this phenomenal, natural resource and destroying it. No wonder we have no bodies.
Well, it's interesting because what you just said is the pushback that I got from the 42-hour work week. And, let's be completely honest. Law enforcement struggles a lot more with organizational betrayal on the city, county, or national level than the fire service was. We are disregarded, forgotten about, overlooked, but we're not vilified in the media very often. We are sometimes, but there's a lot of us that do some bad things as well. But it's the build it, they will come model. What's happened with changing the work? You got to remember, these fire departments are also grossly understaffed. In Pasco County, for example, the Tampa side of Florida, I forget exactly how many gaps they had, but they were a revolving door department. People would come in, stay, get trained, and then they go work for somewhere else. And when they announced that they were going to this fourth shift, so remember, you're now having to hire another entire shift of firefighters, hundreds of firefighters, the recruitment line went out the door, because people from around were like, that's an agency that actually gives a shit. That's an agency that doesn't want me to leave at 55, obese, cardiac compromise, et cetera, divorce, alcoholism. And they then have started layering fitness standards, some other things as well, great mental health access. And they went from understaffed with 3 shifts to fully staffed with 4 shifts in 2 years. And so this is, I think, how we fix it. I want to ask you this. I don't know the answer for this. In the law enforcement side, in the fire service, when I entered only 22 years ago, all the way through to about 10 years ago, we were fighting for jobs. People were testing numerous agencies. I walked in with a resume. I was fit. I was, fully prepped for the written test, practiced, oral board tests, all the things, and then my resume grew as I worked for other departments. I took extra classes, et cetera, to try and get a single spot. And then we nosedived in the last 10 years. And it's because of the things that we've discussed, that everyone shoved their head in the sand. They're like, I don't want to hear it, la, 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 rather than we have a problem, we have to get ahead of it. What was the demand in policing that you've seen over the last few decades, and was there a point where people were fighting for law enforcement jobs? Because in the fire service, because we were already there, we're heading back to it now, because we're bringing young people back into this profession by fixing some of the things that are broken. Of course, you've got to have political support from the people that you work for. Organizational betrayal is horrendous and one of the elephants in the room in mental health. But talk to me about the height of recruitment, because if you guys were there once before, then it means that you will be able to get back there again if we address some of these issues.
Yep. It used to be 2,000 people would show up and test for 20 slots. Now we have each agency has a recruitment division. Each agency is trying to outpace it. And you'll drive through Texas and you'll see billboards luring people to Arizona to work. In our trade publications, you will get a $50,000 lateral sign-on bonus. We have people coming into the police department now, joining the police force, who say, well, exact contradistinction to what I said earlier. You were born a cop, you were born a protector. I have seen cops now like, well, I was going to work at Target, but the city benefits are better.
That's not who you want with a gun pulling over your teenage child.
We're hurting, and currently the exodus is higher than than people coming in. We have more people retiring than we have people filling, and we already have vacancies. So it's not getting any better. It's getting worse. How do you fix it? You fix the culture. You don't vilify the police anymore. You give them a degree of latitude in terms of, we have overly prosecutorial district attorneys that look to vilify cops. You have the health and wellness requirements. At least the firefighters have the NFPA 1850 data. They have standards. There's not one standard. I sit on the International Association of Chiefs of Police Physician Committee, and we try to develop standards. But we're 20 years behind the fire service in terms of codifying wellness. So you need to have that codified. You need to make it a definitive, an expectation. When you get out of the police academy, not only do you need to qualify with your weapon once a year, you need to have a height weight standard. You need to be able to run this fitness protocol, whether it's a stationary bike, whether it's a rowing machine, whether it's an obstacle course, whether it's a old school military physical fitness test with run, pull-ups, push-ups, sit-ups. You have to be held to a standard. If you don't have the standard and you don't have the stick and carrot, it doesn't work. But you've got to provide the other things as well. So it's a multi-tiered problem. To answer your question, I think it is fixable because we were there before. Political environments change. Everything changes. And you're right, it goes back and forth, the pendulum. And we'll be back at a point where, police officers are making good money. They're supported by the community. People want to be a cop again. So I don't know Where that pendulum will swing, I believe, in my opinion, it's beginning to swing now, but we're still not where we need to be. When it takes 20 minutes to get an officer to your house because there's been shots fired, we don't have that right now. It's not acceptable.
Well, I think this has been the selling point, because I've said this many times. In some agencies, the changes were made in the fire service because chiefs, union presidents, whoever, city managers cared. And that's how it should be. The end of story. Like, our firefighters are struggling. We got these cancer deaths, we got heart disease deaths, we got these suicides. Something needs to change. The stations are browned out. It's detrimental to the citizens. Something needs to change. But the reality is, a lot of times it's the money. And so what we've been able to do in the fire service is show, well, hey, here's what you're bleeding in recruitment and retention costs, in these crazy overtime costs. I don't know if you've seen any of these stories that have gone out recently about how much these battalion chiefs or firefighters are making in California. LAFD's overtime budget over 4 years is $1.2 billion. I mean, there are stories everywhere. And it's like, okay, don't remove the hype of the title. Look at the underlying issue. If there's overtime, there's vacancies. Now, some overtime, don't get me wrong, might be a wildland deployment. It might be special events. But that much money, clearly you're using overtime to staff because your people don't want to work for you anymore. So, dear citizen, this is the spiraling downward. You won't have a fire department soon. You won't have a police department soon. Is that a good thing or a bad thing? Okay, well, then we need to talk about how your taxes are being used. And if the people that are in power aren't willing to fix it, then maybe we need to get someone else in your leadership that is willing to fix it, because otherwise your child is going to bleed to death in their car or be shot in the school or whatever it is. We're not trying to scaremonger. These are just pure facts that you and I know. When we work for good departments that have quick responses, many, many calls are like, shit, if we didn't get there, if we were 2 minutes later, this would have been so much worse. So, I think now the fact that it's so bad is also our greatest selling tool. And if you could pull how much money is being wasted by this crisis, you can say, well, there's your money to fix the salaries, to start implementing programs that are showing that you're supporting law enforcement, to put in mentorship programs, to put in, DTAC and jiu-jitsu and whatever else needs to be done to show the public, look, we're lessening the chance of someone making a mistake because we've got fitness standards and we've got, hands-on training, so that you haven't got a scared 19-year-old that the only go-to is a pistol because they, like you said, they're 250 pounds, have never been out of breath in their life. So I think it's an exciting time. I do. But sadly, that's because the pendulum has swung so far. Now we have so many negative things to point to. Hopefully that's going to send the pendulum back, and then we can stop it in the middle, not blindly be all law enforcement and no accountability. And, and maybe we're like a George Floyd or Rodney King situation. And then, damn, now the thing's swinging back the other way. So I hope that the fire service's journey will then grab their law enforcement brothers and sisters and then start pulling them the same way.
I hope so too. Yes, absolutely.
All right. Well, just one quick area. I'm going to keep it very brief. When it comes to anyone on this podcast who has been deployed to a combat zone, you mentioned being deployed to the Middle East. There's a couple of questions I normally ask, but I'm just going to pinpoint one. Back to those god-awful TV stations or news stations that we just talked about before, it's very polarizing. In the war situation, it's either, kill them all, stack bodies, or they're all baby killers. And what we never hear about is either, the reasons and the horrors that people actually saw that were there, which we won't get to today. But the other side is also the kindness and compassion that I've heard so many stories of men and women on the front lines, whether it's in the medical space, whether it's actually in combat, the vets that are helping with local animals, et cetera, et cetera. So when you reflect back to your time in the military uniform in that capacity, what are some of the stories of kindness and compassion that really stuck with you?
That's a great question. Okay, I got to frame it from where my perspective lies. And my perspective lies as, I'm not a soldier putting lead downrange. I'm a medical provider. And my role as a cardiologist / critical care provider is providing critical care for wounded. And what I see, I can't think of, I mean, there's countless stories of selflessness and camaraderie, but what sticks, as you ask that question, the thing that sticks in my mind the most is um, the selfless sacrifice. Talk about a group of young men and women that don't make very much money, put their lives on the line, are injured, and then have to go back and now have this lifelong injury, whether it's physical, traumatic. I will tell you, I'm a 100% disabled vet. I've seen stuff. I have some medical issues, a bunch of back issues, some PTSD from it. The scars that you have had 5 spine surgeries, and the scars that you carry, both physical and mental, these are products of selflessness. So the young men and women who reach the front lines or reach the deployment, or they join the military, they're giving so much of themselves that it is an honor and a privilege to have these people as your friends and your colleagues and to take care of them. So what I was struck most by was people just there doing their job, whether they agreed with what we were doing, whether they didn't agree with it. They were given a job. They did their best and suffered the consequences. So the camaraderie, we're all in it together. It's a mission, not just a paycheck. The selfless sacrifice of all the men and women that are not just unfortunately killed in action, but physically or emotionally, mentally hurt. It's incredibly moving. And, you mentioned earlier the VA, and I am I'm a recipient of VA benefits. And my family has been so incredibly indebted to the VA. It's been so much, not just medical care, but support. And we have the ability to continue to do this. So to answer your question I don't really have specific examples, except the fact that you're looking at a population of young men and women who give of themselves so much, expect such little in return, and are willing to sacrifice everything for core fundamental beliefs. And those fundamental beliefs may be as high as I love my country, or maybe, which people don't realize on a much smaller level, is I love my friends in my unit. I'm going to live or die for them. I'm sitting out here in the middle of in Afghanistan, in the hills of, Operation Anaconda. I'm not thinking about the Constitution of the United States. I'm thinking about getting my teammates, my buddies, to survive, whether it's through suppressive fire or through medical care. That's what you're looking at. You're looking at these young men and women who give of themselves tremendously. They don't ask for much. So I always talk to people, you don't have to be politically in agreement with the policies and procedures of the White House, but the troops go blindly. The troops don't have the luxury of looking at a conflict going, yeah, I think this is a just conflict. I think I'll go. You sign up, you go, and you go where you're told to go, and you go whether you believe it's right or not. And I think that has to be maintained. That concept has to be maintained, and know that our troops are really out there giving their all. They're young men and women in their 20s on our ships, on our planes, in the field. These are our children, and they deserve our unwavering support, even if you disagree with what the overall mission is, because it's not their choice. I'll end on that.
I've used what we've already talked about as a comparison when it comes to healthcare. Knowing that there are a lot of people that line politicians' pockets, that have companies that make things, weapons, MREs, rebuilding, whatever it is, that profit from war, the same way that there are, some of the things that we talked about, insurance companies, drug companies, et cetera, that profit from disease. And just like medical interventions, as we talked about, there are some that are phenomenal and are 100% needed. And if you reflect back to, for example, I think a good war to look at is World War II. There's a conflict sometimes it's unavoidable that has to be fought, and that self-sacrifice made such a huge impact on the world in a positive way, where are the checks and balances when there are people that profit from war to make sure that we only send our children when is absolutely necessary? And with you having such a powerful lens of the casualties of war and yourself carrying the wounds, I think your voice is important as to, how do we make sure that we just don't keep sending our children in places that arguably are not conflicts that are warranted for the benefit of the United States?
Well, I guess that perspective lies in the person who's viewing the situation, right? So you can have 5 different people looking at the 5 same facts and come up with 5 different opinions as to whether, in this case, that conflict is just or not. So I'm not here to, I can't shed light or debate whether we should judge a conflict just or not. And there's so many levels. I will just go, in fact, and say, and back to the comment that I made, that it's not the individual soldier, airman, seaman, Coast Guardsman who make those decisions. They go, and they go irrespective of whether they think it's right or wrong, because this is the oath they've taken. So I would urge, whether you take 10 people and half think a conflict is just, half think the conflict is not just, at the end of the day, those 10 people should still understand that the troops are there making very little money, putting their lives on the line, their futures on the line. They don't see their kids, their young children just doing their job. So again, it's a political question, which I don't pretend to have answers to. But I would just say, look, having been there, I support the young war fighters who are doing their best.
Yeah, I don't think it's political. I think that when you are not wearing a uniform, you also have the ability to be one voice into whether we're dragged into another conflict or we use diplomacy and avoid a conflict. So I think the other side of the spectrum is if we just shrug our shoulders and go, oh, well, we're going to war again, that's not very democratic either. I think we do have a voice, and, there are times where we are taken to a conflict and there would still be opposition to that. But most people are like, yeah, that was justified. And, I lost my loved one, but my God, the collective movement of what they did was amazing. And there's other times, and Vietnam is obviously one of those conflicts that you use as an example, where people look back and go, well, what did we really do? And I think that, the country, every single member of the United States of America has the right to say, this isn't right. I don't want my child in uniform who will fight selflessly and won't question it to die for this particular thing. So I think that there's an opportunity for, again, middle of the road conversation there. And again, sometimes people label it politics, so we shut the fuck up and don't discuss it. And I think sometimes we should.
Yeah, I agree. And but again, you talk about a just cause. You talk about morally and ethically legitimate. You're going to talk to 50 people and get 50 completely different answers. So we are a republic, not a true democracy, right? We don't vote on every issue, unless you're in California. Apparently they do out there. But our republic relies on our executives and our appointed officials, our elected officials, to make those decisions. But you're right, the pendulum, it takes a long, so we don't like the way the country's going. We change the Congress, we change the Senate, we change the presidency. And so hopefully the country can adapt. It just doesn't have, things still happen slowly where the world spins rather quickly these days.
Absolutely. All right, let's move to some closing questions. I'll be mindful of your time. The first one I love to ask, is there a book or are there books that you love to recommend? It can be related to our conversation today or completely unrelated.
The book, from a medical perspective, that really handles everything I talked about is a book by a gentleman named Robert Lustig. He's a pediatric endocrinologist at San Francisco, University of California, San Francisco. It's called Fat Chance. He talks about particle size, LDL, fructose, sugars being bad, not fat. So for your listeners who are looking for a medical book that gives them a good guidance of what we should look for, he's got a great book, Fat Chance.
And he said he's pediatric?
Well, he's a pediatrics endocrinologist, but he's written for adults. It's not written for children. I mean, it's written taking care of adults. And some of his chapters are overly biochemical and too complex. Some of them are great, but he's a tremendously well written, brilliant man. Robert Lustig.
What is, if it's in the books, what is his perspective on the increase of diabetics in pediatrics, in the childhood obesity?
Oh, it's huge. He spends a huge amount on that. For the first time in human history, more people are dying from the complications of obesity than starvation. And for the first time in history, our children have shorter life expectancies than their parents. And it's all due to sugar. Yeah. It's all due to big gulps. It's all due, when you buy a Coke 30 years ago, you got a little bottle of Coke. Now you get a 60-ounce Dr. Pepper, Childhood obesity is a huge problem, and it's talk about making profits on things that juices and sodas. It's killing us. Sugared cereal, sugared sodas, they're worse than cigarettes. So he's got a lot to say on that, but it's a tremendously good read.
Maybe someone need to try and get on the show then.
Yeah, Robert Lustig, brilliant man. I've never had the pleasure of meeting him, but he also does a bunch of videos, Sugar, the Bitter Truth, and things like that. Brilliant. I recommend his work all the time. In terms of a book that is shaped, I usually like to read books. I usually like to read books to escape, not because I want to be mentally, but I have enough trauma and enough emotional volatility in my life with 6 kids, a police officer job, a physician. I look to read to escape. So I read a bunch of sort of, spy novels because I like this stuff. But one book that I really like that's got nothing to do with it is called Illusions, A Tale of a Reluctant Messiah. It's about a barnstorming pilot who travels through the United States in a biplane, and he runs into someone else who's doing it, who's basically the Messiah who doesn't want to do it anymore. And he's just flying around the country. You can read the book in a few hours. It's a short book, and it's a phenomenal read. I won't ruin it for your folks, but it's called Tales of Illusions, Tales of a Reluctant Messiah. And it sort of questions what we call reality. It's just kind of a really enjoyable, good. It's a book's 40 years old. And it's written by author Richard Bach, B-A-C-H.
Beautiful. I never heard that one mentioned before.
He wrote Jonathan Livingston Seagull. It's just a really good book. And it's a short book, but it's definitely it's an enjoyable book. I read it a few times a year.
What about film, television, or documentaries? Any of those that you love?
I happen to really like all Taylor Sheridan's books. I mean, all Taylor Sheridan's films, all his TV shows. I watch Yellowstone, and I think, yeah, I'm a cowboy. And my wife, you're not a cow. You would die out there. You're not a cowboy. And I'm like, no, I think I'm a cowboy. And she said, no, I don't care if you wear boots or not. You're not a cowboy. So I love all Taylor Sheridan stuff. In terms of movies, I'm still a classic 1980s guy. I think the ridiculous movies like The Hollywood Knights, Stripes, Fletch, the old school Step Brothers, that's the stuff I like to read. It's mindless, funny humor. I like to watch.
You mentioned that you worked on a U.S. Marshals task force. How accurate is Taylor Sheridan's Marshals?
Incredibly inaccurate.
I figured that was the case.
Yeah, incredibly inaccurate. Yeah, because you don't just come on a marshal, you can give a badge. I mean, you become a task force officer, but you got to be a cop. It's a lot, and the missions are very different than what they do. But let me tell you, that was probably the most rewarding police work I've ever done.
What were some of the calls you remember from that?
Oh my God, just going after the worst of the worst, fugitives that are, you want to keep people clean. You want to keep the streets clean. Take away the criminals who are still out there. take away the people who've already committed crimes who are on the loose. That's the best way, because they're going to keep committing crimes. We picked up the worst: murderers, rapists, all the fugitives that were federal and local state fugitives are given to the marshals to track down and get. And let me tell you, these guys are good. They find them, and they're able to operate with very good equipment, very good intel. And the problem isn't capturing or detaining these folks; is keeping them in jail, because the prison system is a revolving door, unfortunately. But that was exciting, adrenaline spiking. I've done SWAT, I've done fugitive apprehension. Fugitive apprehension is more exciting than SWAT. It's a lot of fun. Talk about adrenaline rush. Yeah.
All right. Well, speaking of amazing people, is there a person you'd recommend to come on this podcast as a guest to speak to the first responders, military, and associated professionals of the world?
There's a couple. There's a Dr. Maybury, who was one of the medics in Black Hawk Down in Somalia, who after got out of there became a medical student. I don't know him very well. I've worked with him a few times over the years, but he's a physician now who spent his career in the military trying to shape military medical policy. Brilliant guy. I think his name is Bob, is his first name, Dr. Maybury. I also there's a few doctors in the country that are sworn police officers. There's not many of us, but there's a few. There's a couple guys, Andrew Dennis and Alex Eastman. Similar backgrounds, but they're both surgeons and they work in different capacities. They both focus. Alex was the medical director of Homeland Security for a while. I think he still may be until this term is out. But interesting people that can bridge the concepts of, they're multidimensional. They're what we would call, what Benjamin Franklin was a polymath, person who does everything. You have people that are doctors and cops and professors of medicine. That's an incredibly well-rounded person with incredible amounts of experience. So Andrew Dennis and Alex Eastman are two brilliant folks that I would bring on as well, because they can share some of the same stuff I've done at the same time, from different perspectives. So there's a few people out there.
Beautiful. All right. Well, then the last question before we make sure everyone knows where to find you. What do you do to decompress?
I have two things I do. One I do daily and one I do every week or two. Daily is I hit the gym. That is my day. I am bombarded constantly all day with multiple tasks constantly at the same time. But when I'm in the gym and I'm lifting weights, I'm focusing on one thing. I got music in my ears and I'm just lifting. So that is my clear space. And then my other happy space is my wife and I have an RV, and my wife is literally my partner in this world. And she and I take our RV out on the weekends and we go to a little town in Texas called Fredericksburg. And we have a little place we set the RV. It's a little area we go, and it overlooks this big valley, and it's quiet, and the stars are out, and I can just sit out there, and when I'm out there with my wife overlooking this Luckenbach Valley, I'm thinking, man, there's no place I'd rather be at this moment, and nobody else I'd rather be with. That is the ultimate relaxation piece for me. Matter of fact, I'm going to send you a picture of that before we hang up and show you what it looks like, because I was sitting out there having a cocktail with my wife just last week and thinking, this is what it's all about. It's not fancy. Don't get me wrong, it's a nice RV, but it's a 10-year-old RV, but we love it. And that's my decompression time.
It's amazing how often, obviously family, but also nature. For so many of us, especially if we're working in the urban setting, and it's the forest, it's the beach, it's the mountains, it's the valley, and we forget. We get so pulled into buildings and manufactured lighting and stresses and computer screens, and all we're going back to what our grandparents did. We're just going back to that. Most of evolution, we've been outside.
Right. I like to sit out there with my wife, glass of wine, a cocktail, my dogs, and just do nothing and just decompress. It is the most relaxed at peace I have ever been in that one situation. And I look forward to it.
Brilliant. All right. Well, then the very last thing, you mentioned that you have a company that does the testing that we've discussed already. So let's talk about that first. What's the name of the company? And if people want to go down that route, where can they find it?
So I created a company about 10 years ago called Sigma. It's SIGMA, Sigma Tactical Wellness. Our website is iamsigma.com. And we're a company that's screened over 40,000 police officers so far, which is only scratching the surface because we have over 1 million police officers in the United States. We're able to come into a police agency, identify heart disease, and we don't just identify it, we treat it. So there's one thing to have an agency that hires a screening company to identify people who are at risk. And once that is done, the people are still in the same boat if they don't act on that risk. But Sigma not only identifies risk, but we treat it. So we'll come in, we'll screen a population of officers for heart disease, which, by the way, about 40+% have found to be at high risk. And then we offer the treatment. Our providers, our doctors, our nurse practitioners will provide exercise nutrition counseling. They provide prescriptions for cholesterol-lowering medication, recommendations for supplementation. And then when that visit is over, the person is treated. Now, they can go back to their primary doctor, or we refer them to a telemedicine company to continue telemedicine care if they want, if that's more convenient for them. But when we were screening people without treating them, we found that we go into an agency, we screen an agency, 1/3 at least would less than 1/3 would get the results. They go to their doctor, the doctor would look at it and go, this is interesting. I'm not familiar with these PLA2 markers, but that's interesting. I see this literature. Let's get you treated. But a second group would go to the doctor would look at their work, go, I don't know what the hell this is. I never heard of these people, this stupid test. Don't worry about it. Your cholesterol's fine. Again, it's not about cholesterol. And the third group wouldn't go. And what we did is when we do quality control, and we go back and look at an agency, and we found out, we screened this agency a year ago, and there were 2 heart attacks this year. I want to make sure we didn't miss anything. We did not screw up. And 100% of the time, we weren't missed. We didn't miss anything. We identified a problem, and that person failed to get the proper follow-up. So our company, Sigma Tactical Wellness, comes into police departments. Police departments use allocated funds. They use seized funds. They use grant funds. They use funds donated from the agents, from the association or union, and they fund the screening. And it has a 30 to 60 return on investment in terms of saving healthcare dollars. One screening is a full screening is $700 and some odd dollars, $700, $900. One in-service heart attack costs an agency between $500 and $750,000. We can screen almost 1,000 people for the cost of one heart attack. Unbelievable. So that's the company that is having, now you and I visited for a couple hours. As a physician, as a law enforcement officer, that is the perfect blend of my careers, keeping cops healthy, alive, and on the job.
I love it. And again, going back to that, false economy of the way we do it and that proactive spending, this is the issue that I see where people are, well, it's hard to annotate. It's like, well, good. I'm glad that people not dying is hard for you to annotate, but we're understanding that if you're investing in healthy cops with all the things that we talked about today, or healthy firefighters, then the fact that there's an absence of all the things that were killing us before, if you remember how it used to be, well, there's your data there. But this is one of the challenges. Well, where's the data? It's like, well, because people aren't dying. I mean, the data, I always tell people, is in the graveyards. If you want to go count the data, take some flowers with you, off you go. But these proactive initiatives, not only from a humanitarian point of view and a leadership point of view, are needed. But even if all you care about is the dollars and the cents, the way you're doing now isn't working. And these proactive initiatives of making happier, fitter, well-rested cops, firefighters, EMTs, corrections officers, dispatchers, that is the way that you turn around these financial crises, these recruitment crises that we're seeing all over the country.
I agree.
All right. So if people want to learn more about you specifically, reach out to you, where are the best places to do that online?
The best way to reach me is through the Sigma website. There's a contact us button. They can send a message that come right to me. It's iamsigma.com. There's also a bio on there explaining who I am, what I've done, list of my publications. That's the best clearinghouse for me. I mean, you can Google me and come up with 100 different things, but the reality is iamsigma.com. And if there's any questions your audience has, or there's anything I can do to help push forth this, I hate to say it because it sounds sick when you say this agenda, but I want to get the word out there. My job, my mission in life is not running traffic. It's keeping cops alive. And the more people I can get and the more people I can touch, the more people I can affect, the more lives we can save.
Absolutely. Well, I want to thank you so much. It's been such an incredible conversation. As we've discussed many times, the lens of medical and law enforcement together have been so powerful in a number of the areas that we've visited. So I want to thank you so much for being so generous with your time, almost 2.5 hours today, and coming on the Behind the Shield podcast.
Well, thank you, James. It's been a pleasure.